This conference will now be recorded.
All right, so we have a fairly short presentation on lifespan development. Honestly, the EMT went longer. So really nothing's really changed in lifespan. It's going to be the same thing as it was for your EMT class as you move through. So just kind of bear with it. And then we'll cover principles of pharmacology next. All right, so we're going to meet national EMS standard competencies, applying the fundamental knowledge of the lifespan development and patient assessment and management. Having an idea of the different body systems, looking at the age groups we deal with, how we're going to handle the different types of patients we come in contact with as far as age ranges go, will help us have a better understanding of how they think, their thought process, and things like that. Also, like how they evolve through life. So the human, human beings evolve throughout their lifespans, right? So we start from the neonatal to infancy, moving our way up into geriatric. So AEMTs obviously must be aware of the changes in person undergoes at various stages of life, and they have to alter the approach to patient care. Correct. We have to make sure that we are approaching our patients with respect. Remember, they are calling us in their time of need, so that is the scariest moment of their life, is why they call 911, that we show up and in hopes calm them down and kind of work with them. But the way we approach our patients is going to be different depending on age group. And we'll talk more about that in each age group coming forward. So obviously neonatals are birth to 1 month old. So birth, 30 days, right? That's our neonatal range. Remember that I also mentioned the neonatal fluid administration. What was that from last class? What was the neonatal fluid administration? As you can see, this is important information as far as how we're going to be treating our patients. We're going to kind of cover a lot of the treatments in as well. So Ken, you got the 10 ml correct, but we have to go by weight as well. So it'd be 10 ml per kilo or kilogram, kg. Very important, remember, because as the body grows, they can take on more fluids. As a neonate, you're lucky to even have 500 mLs of fluid in the system itself. Really, it's just a Coke can of blood supplies that entire body, and even less as a neonate. Going into pediatrics, it goes up to about a Coke can, a little bit older too. Perfect. All right. With infants, it's 1 month to 1 year old. All right, that's gonna be our time frame there. So some of the changes we're gonna find in the neonatal, the infancy, are gonna be vital signs. So the younger the person, the faster the pulse rate and respiration. So we're gonna see increased respiratory rate. We're gonna see increased heart rate, and the respiratory rate roughly between 30 and 60. Right, depending on the age group. So I'm going to give you guys a couple different ones here to remember. Pediatric is roughly 25 to 50 breaths per minute. That's the average. Anything greater than 50, they're tachypnic. Anything less is Brady, right? So if you saw 25 in an adult, would that be normal? No, because a normal respiratory rate, okay, for an adult at 25 is too high. They'd be tachypnic, right? Because our normal rate is 25. I got it, Rosa. 25 to 50. I'm sorry. My goodness, 12 to 20 for the adults. Child goes 15 to 30, and then 25 to 50 for your infant. Kind of some rough BLS numbers to remember. Now, if you had a patient, like look at their at birth, the heart rate goes between like 90 and 205 beats per minute. If you had a pediatric and had a heart rate of 50, what would you be doing at this point? A pediatric with a heart rate of 50. Yeah, that'd definitely be worrying. But what else are we doing for this kid? Feel free to unmute and talk too if you'd like also. But compressions, right? Anything less than 60 in a pediatric, we start CPR. But if you had if you had an adult with a heart rate of 60, that's within normal range between 60 and 100, right? So our numbers change based on the age group that we're dealing with. So within the first half hour after birth, a neonate's pulse often drops to 120 beats per minute, and the respiratory rate falls between 30 and 40, right? So at birth, we're looking at 90 to 205 with a respiratory rate of 30 to 60. Half an hour, it drops from, let's say, the 200s down to 120. That's normal ranges for us, 120 beats a minute with respiratory rate between 30 and 40. By age 1 year, we're going to start seeing the respiratory rate start to slow down, and now we're going to start seeing between 20 and 30 breaths a minute. So here's something else also to remember as well. These are the numbers you need to understand, especially as we're ventilating patients. Yes, in BLS, we're taught, give enough breath to look for what?
Chest rise?
Yeah, exactly. Chest rise. Perfect. All right. However, we're looking at also more specific numbers now, moving into the advanced level, even in the paramedic level, of what we're looking for. So the tidal volume in a neonate starts between 6 to 8 mLs per kilogram. Right? That's when it starts, 6 to 8 mLs per kilo. But it will increase to 10 to 15 mLs per kilo by the end of the first year, as far as tidal volume, right? That doesn't mean how much we put air in, okay? It's going to be a lot less than that air going in, but the normal tidal volume for a neonate starts at 6 to 8 mLs per kilo and then increases to 10 to 15 at the end of the first year. Blood pressure corresponds with the patient's age, right? So at birth, the average systolic blood pressure of a neonate is 67 to 84 and 85 to 104 by 1 year of age. Now, also keep in mind with blood pressures, if you do not have a cuff small enough to fit the infant, we can't obtain a blood pressure. All right. So we do carry infant blood pressures all the way up. We should be. I know we do where I work. We also have the availability of those in our cardiac monitors. And if they're not, then they need to be put on the truck type thing. All right. So again, we got to make sure you have the right equipment to do your job to be able to get these blood pressures. A neonate's normal body temperature runs between 98 degrees Fahrenheit to 100, while the infant's normal body temperature ranges 96.8 to 99.6. So these are all very important numbers to know. And they do make little cheat cards as well that you can carry like on the back of like your ID badge or put in your wallet. You're going to memorize all these for testing, for school, and unless you keep up on it, sometimes you tend to forget. Understandable. We don't do a lot of pediatric calls. Most of our call volume is adults, geriatrics, and things like that. So we don't usually see a lot of the pediatric neonatal assessment. So the weight, looking at weight, a neonate usually weighs between 6 to 8 pounds. Remember, you got to convert those down. So it's 3 to 3.5 kilograms at birth. The head accounts for 25% of an infant's body weight. Another thing to think about as well is in the first week after birth, the neonates lose 5 to 10% of their birth weight due to fluid loss. 5 to 10%. By week 2, neonates then grow at a rate of about 1 ounce per day, doubling their weight by 4 to 6 months and tripling it by the end of the first year. So why would that be important to know? Why is that important for us to know about birth weight?
For medication administration?
Okay, that does help. Yeah, exactly. Medication is done by weight base, but why else though? Look past the meds, George. Look a little past that. We want to make sure that they're getting enough nutrients. Exactly, Rosa. Perfect. So we have, George is correct though. We do need to know the weight because everything's weight-based in pediatrics. So good job, George, on that one there. And Rosa, same thing as well with you. Great job putting that in there because it's they got to make sure we get enough nutrients. So if we're doing an assessment and we notice that they're way under what their weight should be, right? Could it be something with malnutrition? Could it be some form of abuse, right? I'm not saying that because of low body weight that they're being abused by their parents. I'm not saying that in any way, shape, or form, but something to consider. Okay, why is their body weight lower than what it should be? Okay, so if they weigh let's say 6 pounds, okay, at the end of the first year, they should be tripling that weight. Tripling by the time they're 1 year old. The cardiovascular system. At birth, the neonate makes the transition from fetal to independent circulation. So as they're born, they make that changeover as well. Looking at the pulmonary system, neonates are primarily nose breathers, right? Which is why we have to make sure that we keep their nasal passage open and clean. So on our ambulances, we do carry bulb syringes, and bulb syringes are phenomenal for sucking out whatever gunk and mucus that ends up in a kid's nose. If we use regular suction, we have to be very, very careful. The bulb syringe actually pulls out just enough so we don't deplete the infant of oxygen, versus us using a house suction or a portable suction. If we leave it in there for 15 seconds, sucking everything out of there, it potentially could cause the infant's pulse oximetry to drop as well. So just some other things to think about as you're going through this with your assessment. Infants younger than 6 months are particularly prone to nasal congestion, which can lead to upper respiratory infections as well. So you want to make sure ensure that the infant's nasal passages are clear and obstructed by any mucus. So again, bulb syringe, pull it out. The infant's rib cage is also less rigid than in adults and also sits more horizontally. So infants become belly breathers. Because if accessory muscles are immature, fatigue can set in quickly because of their belly breathing that they're having, right? So to kind of go a little more in depth with this, belly breathing is good. What if I told you that the infant was seesaw breathing? What would that mean? Does it mean that they're okay?
Paradoxical motion.
Okay. So we're going up and down, up and down, up and down, right? That's a sign of a neonate or an infant in severe respiratory distress, with nasal flaring as well, head bobbing being another one. So again, we're going to cover more of that in pediatrics, but you got to pay attention that if you see belly breathing, it's okay. If you see chest up, stomach down, chest down, stomach up, and back and forth like a seesaw, now we know they're in distress. An infant also has a proportionally larger tongue and a shorter, narrower, less stable airway. Why?
Haven't grown into it yet?
What was that?
Haven't grown into it yet?
Well, they haven't grown into it. You're right. That's part of it. But what about the actual structure of it? Yeah, Kobe's saying the tongue is larger. Yep. What else? Why would the airway be more easily obstructed? Why is it less stable?
Because the tongue can turn into an airway obstruction.
Yep. Okay, that's good. Exactly, they can. And some techniques that you can utilize to move the tongue out of the way for airway management is you can use a tongue depressor to pull the tongue up so you can put in different airways. So that's one method you can utilize. But what about the airway itself, not just the tongue? What about the trachea, more specifically? More specifically, the trachea. Airway is smaller in proportion. You're right. It is, Kobe, correct. Weak muscles, definitely in the abdominal and chest cavities. Mike, I saw that there. Also not fully formed. You're right. The trachea is not fully formed. So that way it's more pliable, right? It's more flexible. So if an infant is laying down, and what else is also proportionally larger? The head. So think about when you're doing, hyperflexion, right? So you lay the baby down, shoulders hit the floor, right? And what is the head going to do? It's going to push forward, causing that more flexible trachea to collapse. One of the things that's not fully developed in the trachea of a pediatric or infant is the cartilaginous rings that make that support. So without them having cartilaginous rings strong enough to support the trachea to stay open, we're going to have them close off. So we want to make sure that we are definitely padding underneath the shoulders. If we're doing anything with airway management for a pediatric, we have to have them sit up. All right. So for there are also fewer alveoli as well in the lungs, but then can decrease the surface area for gas exchange. What is the liquid around the alveoli called that helps with elasticity for better gas exchange? You remember what that's called? It helps because of the S. Yep. Yeah, surfactant. Exactly. So, and the thing is a lot of people, a lot of infants can have surfactant levels being decreased, so they end up doing other procedures in the like the NICU and the PICU to help build that back up again. So there are fewer alveoli in the lungs, which then decreases the surface area for gas exchange. For bag valve mask ventilation, remember that in infants' lungs are fragile, so we don't want to do too forceful ventilations. This can result in trauma from pressure or what they call barotrauma. So as we ventilate, once again, back to what I said, what do you look for is going to be chest rise, right? So if you overventilate, we can actually pop lungs and cause a pneumothorax. Not something that we want to happen. All right, so let's talk about the nervous system. So remember that the nervous system continues to evolve after birth. A neonate is born with certain reflexes, what they call a Moro reflex, which is a startle reflex that happens when a neonate is surprised by something or someone. The neonate then opens his arms wide, spreads the fingers, and seems to grab at things. That's one. The second one is what they call a palmar grasp, which occurs when an object is placed into a neonate's palm. All right, so let's talk about the first one, okay, the Moro reflex, startle reflex, right? So we want to make sure that we can check these reflexes neurologically, right, with an infant. So we can take and we can startle them, snap our fingers, see if they follow it, see if they make that movement, right? As far as a palmar grasp, I'll hand like the neonate or an infant, I'll hand them my pen and see if they'll actually reach out and grab to make sure they have good reflexes there. So the rooting reflex takes place when something touches a neonate's cheek. The neonate will then instinctively turn the head towards the touch. So we start rubbing the cheeks of the infant and see if they'll turn their head back and forth. The last one is called a sucking reflex, which occurs when the infant's lips are stroked. You take your gloved hand, you can stroke the lips and see if they make that sucking movement. This is how you do a very in-depth and good neuro assessment to checking reflexes on an infant. So the Moro reflex, palmar grasp, the rooting reflex, and the sucking reflex. So the next time you have an infant, try these. See how they work for you. Fontanelles allow for the head to be molded, right? So there are 4 bones of the skull which eventually bind together and form suture joints, which we talked about before, right? So we have 2 different fontanelles. The first one is the posterior fontanelle, which usually fuses by 3 months of age, and the anterior fontanelle, which usually fuses between 9 and 18 months of age. And let's see if I can do this here. All right. So what's significant about the one I just circled, the anterior fontanelle? What are some things we can tell?
That should let you know if it's bulging, you have ICP, or if it's concave, then dehydration.
Exactly. So if we have an infant, and here comes some of the pharmacology stuff, which we're going to be covering in the next chapter anyways. So let's just say we have a infant that weighs 10 pounds. How much fluid can we give them?
Uh, 10 mLs per kilogram.
Okay. Patient weighs 10 pounds. What's the math come out to?
220 mLs.
That's a lot. That's a lot. So 10 pounds, right? We got to convert that to kilograms first, right?
Oh, 45 mLs.
Yeah, 45 to 50, right around there somewhere. Right. So do we really want to hang a bag of fluid on these patients? We can't measure that to the T, right? So these patients here, which I will show you guys on a practical day, is hanging a bag, utilizing a three-way stopcock and pulling the amount of fluid that you need to administer to these patients to treat dehydration. And we're using syringes. And then we give them a 10 ml boluses, or you do 20s, things like that.
Hey, Kevin.
Yeah.
Could you also, instead of hanging like a 10 drop set, could you hang a 60 drop set?
You can, but again, you have to be able to measure to the precise number. So let me ask you this. So since you and I get all the crazy calls, how do you, if you hang a bag of fluid, everybody in the classes, I mean, you guys have all been in this field for a little bit, at least a month or so, and you've all seen saline bags of fluid. Can you get exact numbers on those for administration?
No, because it's just a bag of fluid.
Right. So how do we get something more precise? There's two different options we can utilize.
IV pump.
You can use an IV pump, but I probably would use one for 50 mLs of fluid. But yes, and you guys can't use IV pumps. I'm looking at the chat, everybody's saying syringe, syringe, syringe. And there's one other thing that we can utilize, and it's on our ambulances in New Hampshire. But no one ever takes them out, and they look at the checklist and go, what the hell is that? A butyrol
could
set.
you use one of the sleeves?
A butyrol set.
Oh. Okay.
Otherwise known as the Barrett set. So what it is, it's a chamber that has more precise measurement that hooks into the bottom of an IV bag. So what you do is you fill the chamber, then you open up your second stop, open that up, and then that fluid goes into the patient precisely. Okay? But nothing's going to be more accurate than what you pull in to a syringe. But there are other methods that are out there. So I do apologize for going off topic. I kind of wanted to cover more of the infant stuff and hit you guys with some pharmacology with it and kind of prep you for the next lecture. But good talk, good thought process behind it. We're thinking, we're looking at the stuff that we carry and what we have to be able to treat these patients. And I can't stress enough on how critical it is to make sure you get things right with kids, because they're very precise. So the musculoskeletal system, we have growth plates, which aid in the lengthening the bones. The epithelial plates, which would be epithelial plates, which are located at either end of the infant's long bones and aid in lengthening a child's bone, right? So if we have fractures, how important is it to actually stabilize these? To recognize a fracture and stabilize? Very, right? Because we can actually do damage to these growth plates. And it can actually stunt their growth or stunt growth in a certain leg, arm, whatever it may be. So we got to make sure we take care of these appropriately. Bones grow in thickness by building on themselves, so they get bigger and bigger as they grow, and eventually they stop. All right, as far as neonates and infants in the renal system, infants can become dehydrated easily because of their kidneys usually cannot produce concentrated urine. An infant's urine consists mainly of water, which can cause the development of electrolyte imbalances. What else can cause significant dehydration?
Vomiting.
Vomiting, fever. Yep, what else? And the other side, diarrhea. Okay. So some of the questions we want to make sure we're asking patients in our history taking is, how many wet diapers have they had in the last hour? Right? That's also very important. If they haven't had wet diapers in hours, that's a problem. They're not producing urine. Why? We gotta look more into it. As far as the immune system goes, for the first 6 months of life, the immune system maintains some of the mother's immunities. So the infant has a natural acquired and some passive immunities with that. Infants can also receive antibodies through breastfeeding as well. Some of the psychosocial changes begin at birth and evolve as the infant interacts with and reacts to the environment. So rapid changings occur within the first year of life. You'll start seeing that. Also, crying is the primary method of communicating distress for most infants. If an infant is non-consolable by mom or dad, is that a problem?
Yes.
Why? What are your thoughts on it?
Big sign of distress.
Yep, big sign of distress. They should be consolable, right? So is crying a good thing? Yeah, it is, right?
Yes.
Okay, because now we know they have an open airway. Okay, if you get called for an unresponsive infant, you get there and they're crying, that's a good sign, right? Now you got to find out why. What happened to cause them to cry? What was that if they're not consolable? So you say, yes, good, patent airway. Why can't they be consoled by mom? Now let's take more of an investigative look. Okay, and we look for everything. Baby gets naked, we strip them down, we assess the patient, especially if they're unresponsive. Okay, look for anything that could potentially be going on. Palpate, feel, inspect, listen, auscultate, the whole deal. Some other psychosocial changes. Obviously, bonding is based on a secure attachment. So secure attachment occurs when infants understand that the parents or caregivers will be responsive to their needs. Okay. The anxious or avoidant attachment is found in infants who are repeatedly rejected. So infants will show little emotional response to their parents or caregivers and treat them as they would strangers. Separation anxiety is common in older infants between 10 to 18 months old. So why is this stuff important? Why is it important to know about the anxious avoidant attachment versus the true bonding versus separation anxiety? What do you think about this?
It's from when
Is
you're
the child
assessing the child originally, just looking to see if they're actually safe and how well they're growing and with their parents.
Yeah. So if they have anxious avoidant attachment, do you think that the child is being treated appropriately at home? Again, we don't make accusations, but are they red flags that pop up? Yeah, definitely. Look at those red flags that are there. Okay. Trust and mistrust refers to a stage of development from birth to about 18 months. So most infants desire a planned, organized routine, and they gain trust in their caregivers or develop a sense of mistrust because things are not going based on a routine that you started. Okay, so you can pick up on these different signs as you're assessing the patient, how the patient is running around the house to how they react with their parents. There's a lot of things that can be looked at with this. Sorry about that. I'm back. All right. So let's talk about toddlers. 1 to 3 years, and then the preschoolers 3 to 6. So I don't know everybody in the class, but who has this age range right now currently? 1 to 6. I know I do. Right? If you've never had kids before, it makes it a little more difficult when you start actually treating them. If you have had them before, you'll feel a little more comfortable treating them. Again, everybody acts a little bit differently, but the vital signs should all be there unless there's some kind of congenital issue that's there, right? So look at some of the physical changes of the toddler from 1 to 3 years. The pulse rate is now between 80 and 140 beats a minute. The respiratory rate is between 22 and 37 breaths a minute. Your systolic blood pressure is now between 86 and 106. And the average temperature is between 96.8 and 99.6, usually leveling off at 98.6 by preschool age. Also, another thing as well is the toddler's lungs also continue to develop more terminal bronchioles and alveoli. So now we're going to start seeing higher volume, better gas exchange as well with that. So let's move forward to the preschooler, or 3 to 6, where you start seeing pulse rates between 65 and 120. So what is, and then before I get to that question, respiratory rate 20 to 28 with a systolic blood pressure of 89 to 112. At this point in time, the weight gain should start leveling off. And the only time you see more weight gains when you're going to see the next growth spurt at that point. They do not have a well-developed lung musculature yet as well. So this prevents them from sustaining deeper rapid respirations for an extended period of time. What is the trend now that we're starting to see? I can rephrase the question. What trend are we seeing with the heart rate? We're starting to see it decrease, correct? Perfect. All right. There we go. Probably got to change over. So other things as well with preschools and toddlers are the loss of passive immunity starts to occur. We start seeing more neuromuscular growth because they spend a great deal of time finding out exactly how to use their nervous system and muscles. So walking, toilet training, teeth start to develop more, renal system starts to develop, neuromuscular growth. They learn how to touch, pick up, they feel, they start understanding certain things are bad, certain things are good. Nervous system starts kicking in. By the end of this stage, preschoolers will have a brain that weighs 90% of its final adult weight. Playing places stress on the muscles and bones, which increase muscle mass and bone density, which is good, right? They're outside, they're playing, they're active. Continued development of the renal system, also in elimination patterns start happening. So they start eliminating more waste. Physiologically, toddlers have the neuromuscular control capable of a bladder for bladder control by 12 to 15 months of age. The average age for completion of toilet training is 28 months of age on average. We start seeing teething, which can be very painful, accompanied by a fever. All right. So what is one thing that can be utilized to help with the painful teething? It's not something that we're going to give, but parents might actually do to assist with that. And please don't say fentanyl pops. What actually reduces pain? What else do we have out there?
Whiskey.
There you go. The other one is called sucrose. It's a sugar. Sugar is a great pain management. Sucrose is great for pain management in pediatrics, especially if they're teething like that. That can also help as well. Leading cause of death for this age group is unintentional injuries. What's another thing between 1 and 6-year-olds when they start walking? Do they have any sense of danger? Do they understand what danger is? No, they don't. Right?
No,
That's why
they're
they.
invincible.
What was that? They're invincible?
They're invincible, just like a teenager.
Exactly. Except teenagers have a sense of danger. They just don't care. But infants have no fear. They don't understand what fear is. They're just going to go and they're going to try things out, which is why it's so important to change. When I teach my water rescue programs, we talk a lot about this kind of stuff, about pediatric emergencies by the pools and water, lakes, rivers, oceans, because they're undependable. Next thing you know, you turn your back for a second, they're gone. Right? Next thing you know, they're into the water. So just kind of pay attention to things like that as well. Again, they're undependable in what they do. Some other physiological changes, or psychosocial changes, I should say, would be continuing to learn how to speak and express themselves. So toddlers are very attached to their parents and feel safe around them. Separation anxiety peaks between 10 and 18 months of age. At 36 months, so 3 years of age, basic language is starting to be mastered. They have minds like a sponge and repeat everything that you say. Learn that from experience. All right, who really hasn't? Refinement of this skill continues throughout childhood. So by the ages 3 to 4, most children can use and understand a full sentence. With that, transition from using language to communicate what they want to using language creatively and playfully as well, between the 3 and 4 year range. Interaction and playing games with other children start to begin, which then teaches control, following rules, and competitiveness. By 18 to 24 months, toddlers then begin to understand the cause and effect. If I touch this hot object, it's going to hurt. Maybe I shouldn't do that. Children learn to recognize sexual differences by observing their role models as well. By ages 6 to 12, we start seeing the school-age children physical changes. From 6 to 12 years, a school-age child's vital signs and body gradually approaches those observed in adulthood. So we start seeing our heart rates between 58 to 118. We start seeing respiratory rate going between 18 and 25. And we see a systolic blood pressure between 97 and 120. So we're starting to see more of that adult vital sign. Okay? Just because they have adult vital signs does not mean they receive adult dose of medications. As long as they can fit on a Broslo tape, we're still utilizing weight-based medication. Okay, it's still weight-based, even at 6 years, even at 12 years. So the school-age child, they gain, most children gain about 4 pounds or 2 kilograms and grow about 2.5 inches or 6 centimeters each year. The brain function then starts to develop further in both hemispheres. We start seeing permanent teeth begin to replace children's primary teeth, and unintentional injuries are still the leading cause of death for this age group. Because again, they still don't know everything, so they're still learning and things can happen. Some other psychosocial changes with this is the crucial time in development where the child learns various types of reasoning. So preconventional reasoning being one, where a child acts almost purely to avoid punishment and get what they want. My goodness, do they ever. Controversial reasoning, where a child looks for approval from their peers in society. Post-conventional reasoning is when a child makes decisions guided by their conscience. We also start to begin to develop their self-concept and self-esteem. So self-concept is our perception of others, and self-esteem is how we feel about ourselves and how we fit in with our peers. And YouTube is killing that. My goodness, you kids learn from those. I'm not saying that in a good way. All right, so look at the adolescent between 12 and 18 years old. So physical changes, vital signs begin to level off with the adult ranges. Pulse rate between 50 and 100, respiratory rate between 12 to 20, systolic blood pressure between 110 to 130. So we're starting to see more of the adulthood vital signs. They experience a rapid 2 to 3 year growth spurt, which increased muscle, bone, and bone growth as well, and also other bodily changes. Growth begins with hands and feet, then long bones of the extremities, and then growth of the torso. Girls generally finish growing between the ages of 16, and boys continue until they're 18 years old on average. Muscle mass and bone density are nearly at adult levels at this point, as we tend to grow into that. The reproductive system starts to mature, and then secondary sexual development starts taking place. Unintentional injuries are also the leading cause of death for adolescents. Like Tondra said, we start seeing no fear still. Now we start doing things to impress others. So psychosocial changes with adolescents, where they try to gain control of their lives and independence from their parents, trying to learn how to be themselves. Privacy becomes an issue with this, and we'll go back to that in a second. Self-consciousness increases. Adolescents may struggle to create their own identity at this point, so they use feedback from their families and peers to help create their adult image. Right? They look for us for approval. Often want to be treated like adults, yet cared for like young children. They are very rebellious behavior, can be part of the adolescents trying to find their own identity. And peer pressure is also a major factor, right? We see this. Oh my God, boyfriend broke up with me. Things like that. Then they become suicidal. They become homicidal, not really so much homicidal, but more suicidal than anything else. A lot of times they're doing that for attention, just to be able to talk with somebody, or they actually do have a plan to do something. So let's talk about the privacy thing as well. So if you have a 16-year-old who's been sexually active, right, and there's a potential that she could be pregnant, anyone within childbearing years with unexplained abdominal pain could be an ectopic pregnancy. Okay, that's one of the high possibilities if they are sexually active. So you respond to a residence for a 16-year-old female with extreme abdominal pain. Other than doing the scene safety, BSI, and all that stuff, what are you going to do? What is your assessment going to be like? What do you guys think?
Find out if they've been sexually active.
Okay, yes, we need to know that. But are you going to ask that question in front of their parents?
No, privacy.
Right. So how do you separate the child from the parents to ask this question? Are we going to
Split your partner?
Yeah. So what you do is you have your partner talk to the parents, pull them aside, have a conversation like you want to know more about the patient, right? Yeah, you could ask the parent to go grab something as well. Can you go get this for me? Whatever that may work. But you want to find a way to separate the two to be able to get the information that you're looking for. Now, you're a 40-year-old male EMS provider. Do you honestly think that a 16-year-old is going to tell her she's been sexually active?
Probably not. There's a rapport building that needs to happen.
Right. Is it easier for a female provider to talk to a female about sexual changes and things like that?
Yes.
Absolutely it is, right? But if you're running an all-male crew, you got to find a way to get down to her level and have a conversation with her. You want to get this information out. You got to be able to start your treatment plan, right? So in all reality, we do have to separate the two. I can't remember who mentioned about, one of you guys mentioned about having the other provider talk with the parents. So pull them aside to a different room, have a conversation, the other EMT has a conversation, and try to get more of a detailed assessment on both sides, right? So again, it's all based upon how they change and respecting their privacy. Okay, that's a huge part. Now, 12 leads. This seems to be a topic of discussion. I just got an email the other day in regards to this stuff where I work about 12 leads being done on minors. Does it need to be done? Does it have to be done? Is it a requirement? And if it is a requirement, when do we do it and what presentation, right? So if I have to do a 12 lead on a 13-year-old because they develop chest pain, it still can be something, as long as I try to make sure I have the parent with me and explain to the parent everything I'm doing, why I'm doing it, and going step by step with the patient to let them know where I'm going to put certain stickers onto their chest. Okay? That's why it's so important to be very thorough, to explain everything in detail on what you're doing things in front of parents or away from parents, depending on what the situation is. It's all part of your assessment. Does that make sense to everybody? Okay, awesome. Good. So other antisocial behavior starts to peak in 8th or 9th grade. Eating disorders may develop as teenagers become obsessed with their body image. Self-destructive behaviors such as smoking, drinking, sex, and other high-risk behaviors may start to begin. They have a greater interest in sexual relations. They have a code of personal ethics starts to develop based partly on parents' ethics and values and partly on the influence of the adolescent environment. There's also at higher risk than other populations for suicide and depression, right? They haven't had those life experiences yet. They haven't had the breakups and the deaths in the family and things like that. They haven't experienced that because they're so young, right? So they're going to think that the entire world is over because their boyfriend left them for one of their best friends or something, whatever happened, right? And their life is completely over. It's never going to get better, right? This is where, as parents, we need to understand, hey, we got to talk with them. We got to work them through this. Let them know that there is light at the end of the tunnel, and move through it, right? Or having them seek other help as well. We want to make sure we keep them away from that suicidal or behavior, teach them the rights and the wrongs and things like that. We do the best we possibly can. Watch what groups they're hanging out with. I'm just throwing different ideas that are out there. But again, picking up on the groups they hang out with when you're doing your assessment as well. Looking at the living environment when you walk in the door, to what they have been eating, to what they do for life, what they do for activities, everything else. It all plays one big part of your assessment. Early adults between 19 and 40 years old, we start seeing vital signs between around heart rate around 70 beats a minute. We look at the respiratory rate between 12 and 20, and the systolic blood pressure will be approximately between 90 and 140. From ages 19 to 25, the body should be functioning at its optimal level. Lifelong habits and routines start to develop. We start seeing wear and tear on the bones and changes in the body tissue and muscle begin. Discs of the spine begin to settle, and height sometimes does shrink a little bit, but not much. Fatty tissue starts to increase, which leads to weight gain. Muscle strength decreases, and reflexes start becoming slower. Unintentional injury is a leading cause of death for this age group as well. Some of the psychosocial changes for early adults, where life centers on work, family, and stress. They strive to create a place for themselves in the world, and many do everything they can to settle down. They start getting job stress becomes very high. A lot of times you'll see young marriage and childbirth are common. In the childbirth in this age range is also the most common as well of this age group. One of the most stable periods of life as well, and there are generally fewer psychological problems related to well-being with this as well. For middle adult, like 41 to 60 years old, we see vital signs remain the same. I say the same, but people have hypertension and other issues as well with that. Respiratory rate between 12 and 20 breaths a minute. The systolic blood pressure remains between 90 and 140. The body is still functioning at a high level, but middle adults are vulnerable to vision and hearing loss with other varying degrees of degradation as well. Cardiovascular health becomes an issue in many people, which is why people need to stay active all the time. They kind of make sure that they improve their cardiovascular health as they get older. Cancer incidences increase at this point. They may also begin to have medical symptoms or be unaware of conditions such as diabetes or hypertension. They feel, oh, I'm still young. I don't have to be tested for any of this. Get your yearly checkups, okay? And ask them that question when you're doing the assessment. When's the last time you saw your primary care physician? They may say, oh, I haven't been to one in 20 years. Well, you have hypertension. Menopause takes place in the late 40s or early 50s. Exercise and a healthy diet can diminish many of the effects of aging as well. Unintentional injury is also the leading cause of death of people ages 41 to 44 years old. So for ages 45 to 60, the leading cause of death is cancer. Some of the psychosocial changes also focus on achieving life goals at this age. Life goals. Middle adults also must readjust their lifestyles as children tend to leave home. They get that empty nest syndrome and they're like, oh, it's so quiet in here. What happened? All right, then sometimes they can become lonely. That can actually change a lot of things. During this time also, females may have the urge to want to have another child at this point as well. Finances become a worrisome issue. They have physical and emotional and spiritual reserves to handle life issues as well. And they may find themselves caring for children, leaving for college, and caring for their aging parents as well. So you kick one out of the nest, and now you bring back in your parents. It's kind of like a never-ending cycle, right? And of course, we do anything for our parents, right? So according to the CDC, unintentional injury accidents is the leading cause of death for toddlers and preschoolers, school-age children, adolescents, early adults, and middle-aged adults between 41 to 44 years. For ages 45 to 60, the leading cause of death is cancer. Heart disease and cancer are the leading causes of death in ages 65 and older. We have to make sure we do thorough assessments on everybody. It doesn't matter what age group, from neonate to geriatric, right? We have to make sure that we're doing thorough assessments for these patients to make sure that we're finding the hidden causes, right? This is all part of our differential diagnosis. And the older adults, 61 years and older, we're going to finish up this presentation and take a 15-minute break. We're almost done. The older adults include people ages 61 and older. We start seeing some more physical changes. Life expectancy is constantly changing. So approximately 78 years with maximal life expectancy estimated at 120 years. Based on many factors, including year of birth and the country in which the person lives. Why would they say the country and where they live? What are your thoughts behind that? What are your thoughts behind what country they live in makes, right? Accessible to medical care.
Clean drinking water.
Yeah. I need to see, what about vaccinations? Food, right? You know, a lot of different factors play into this. Heart disease and cancer are the leading causes of death in ages 65 and older. So vital signs are very dependent as well. Overall health, medical conditions, medications taken. That's why it's so important to understand pharmacology. A lot of medications can mask a lot of signs and symptoms depending on what they're taking. Older adults as well often are able to overcome numerous medical conditions, or they may need multiple medications where they have that Sunday through Saturday pill box with 15 different pills based on time of the day, right? So there's a lot of different factors that play into this. One of the biggest things also is to advise patients that if they do have like a lot of medications, is have them make a medication list. Advise them, educate them. So the next time you go back to their home, they can hand you a list of meds versus trying to write everything down on their pharmacy that they have in their own home. The cardiovascular system, cardiac function declines with age, largely due to plaque buildup within the system. Heart rate and cardiac output starts to decrease. Right, we start losing our ejection fractions, things start going down. Cardiac output can no longer meet the demands of the body as the older we get. So our vascular system becomes very stiff. Our diastolic blood pressure then increases with age. The heart must work harder. Blood flow to the organs is more reduced, and the ability to produce replacement blood cells starts to decline, as does the blood volume that you have. Along with that, bone marrow is replaced with fatty tissue. The respiratory system, with that size of the airway increases as smooth muscle weakens, and then the surface area of the alveoli starts to decrease. If we're seeing decreased surface area, are we going to start seeing correct gas exchange? We should be saying no. As things change, we start seeing changes in vital signs, right? Intercostal muscles are used more to breathe. The chest becomes more rigid due to calcification of the ribs to the sternum. Overall strength of the intercostal muscles and diaphragm starts to decrease. Breathing becomes more labor intensive. The chest also becomes more fragile and bone structure weakens overall. Some of the changes that we see are often gradual and go unnoticed until a severe life-threatening condition happens, which is why it's so important to make sure you visit your physicians, right? And make sure you educate them. Our job as EMTs, paramedics, advanced, our job is not just to treat patients, but it's also to educate them as well on getting routine checkups, right? Things like that. Make sure they're being seen. And it also goes more into the public stuff that we offer. We should be offering blood pressure clinics. I can't tell you how many services I've worked for that have offered blood pressure clinics, and we've caught people in their mid-50s with hypertension, and they had no idea they even had it. And so, they're back on medications. They've come back to my department and said, thank you for letting me know this. I had no idea that I was that bad. My doctor now has me on medications and a different diet regimen to help lower my blood pressure. So again, educate them. Our job is not just treating, but also educating to prevent things from happening. Gradual loss of mechanisms that protect the upper airway, decreased ability to clear secretions, as well as decreased cough and gag reflexes. The number of cilia that line the airways diminish, resulting in less sensation and responsiveness when structures of the upper airway are irritated, which then aspiration at that point becomes, or an obstruction becomes more likely. If we aspirate something, we get something into our lungs like food, higher chance of pneumonia, aspiration pneumonia, infection, turns into sepsis, then you die, right? So a lot of things can happen with that. Stand by. Don't let me change slides. I'm not sure why. There we go. All right. Wasn't sure why it wasn't letting me change my slides. So smooth muscle of the lower airway then weakens with age as well, as you can see here in the picture. The smooth muscle in a normal respiratory system, as you can see here, they start collapsing inward, which makes it harder for them to breathe. The vital capacity starts decreasing, residual volume starts increasing. This may result in low flow rates and air trapping as well. So with the smooth muscles in the lower airway weakening with age, the strong inhalation can make the walls of the airway collapse inward and cause inspiratory wheezing. So overall decrease in the metabolic activity of the older body leads to an increased risk of lung infection. So we started seeing more like pneumonia, things like that, bronchitis. By age 75, the vital capacity may amount to only 50% of the vital capacity noted in a young adult. Contributing factors for this would include loss of respiratory muscle, increased stiffness in the thoracic cage, and decreased surface area available for that gas exchange of air, for the air to be able to be exchanged at the alveolar level. So some vital capacity also decreases and residual volume increases with age. Stagnant air remains in the alveoli and hampers gas exchange, which can produce hypercarbia and acidosis. How do we measure acidosis again? What can we utilize to measure acidosis? Other than doing a blood gas, which we can't do. Good, end tidal. Everybody should be participating in this. Right, end tidal CO2. What's our normal range for end tidal?
Isn't it like 45 to 65?
A little bit lower. You have the 45 part right at the high end, but 35 to 45.
35 to 45. Okay.
That's our normal range we're looking for. Perfect. All right. So with older adults as well, the endocrine system, people tend to slow down their physical activity, but tend not to decrease their food intake, right? So now we're not as physically active, but we're still eating a crap ton of food, right? So insulin production drops off and metabolism decreases with age, which makes them more prone to diabetes mellitus, more of the type 2 diabetic. Changes in mental status may also be the result of changes in blood glucose levels. The reproductive system. Men are able to produce sperm long into their 80s, but the rigidity of the penis tends to decrease over time. Women have a decrease in the size of their uterus and the vagina as well. Hormone production for both sexes gradually decrease, and a sexual desire may diminish with age, but does not cease. As far as renal and gastrointestinal, the filtration function declines by 50% from ages 20 to 90 years old. Right? One of the testing that they do is what they call a GFR test, which we covered in our pathophys, right? So the GFR testing needs to be right around 60% or higher. We start getting around the 40% range, 45% range, it makes it very hard for them to filter out anything that they put in. So like one of the things they utilize for, let's say, like a CTA for the chest and they inject dye into the system, they can't get that because they can't filter it back out again. So they actually do what they call a GFR check prior to administering anything for certain procedures. Changes in gastrointestinal function may inhibit nutritional intake and utilization, results in a vitamin or mineral deficiency as well. Decreased ability to clear waste from the body and conserve fluids when needed. The kidney mass decreases 20% over the same span as well. So there's a lot of different changes that are happening as you get older. Taste buds sensitivity starts to decrease. The teeth become weaker. Saliva secretion decreases, reducing the body's ability to produce complex carbohydrates. Gastric motility slows with age because of the loss of intestinal tract neurons, which can lead to feeling constipated or not hungry. Gastric acid secretions start to diminish, which means then he has a hard time breaking down different foods, right? Blood flow and mesenteric vessels drop, decreasing the ability of the intestines to extract nutrients from digested foods. Also, other things is with gallstones, they become more increasingly common, and the anal sphincter changes reduce elasticity and can produce more fecal incontinence. All right. Not to mention, there's a lot of medications out there as well that can cause fecal issues with that, right? Can cause it to really bind up. And one of the biggest ones that does that is narcotic use, right? Chronic pain meds can cause that to happen. As far as the nervous system goes, the brain weight may decrease by 10 to 20% by age 80. Motor and sensory neural networks also become slower and less responsive. The metabolic rate in the older brain does not change, and oxygen consumption remains consistent though. Diminished number of brain cells for the interconnection between the brain cells continue as people age, providing redundancy with the brain, loss of neurons, but not a loss of knowledge or skill. And a lot of times we'll have different sleep patterns as well. So age-related shrinkage creates a void between the brain and the outermost layer of the meninges, which provides room for the brain to move when stressed. Peripheral nerve sensation is diminished and misinterpreted as well. Slower reaction times, slowdown in reflexes, and nerve endings start to deteriorate, and the ability of the skin to sense the surroundings become hindered. Right, so they start losing sensation. So as you can see here in the older adult versus the young adult, there's not a lot of room inside here. You guys can see the mouse, right, that I'm putting around the outside of the brain.
Yes.
Yes. Okay, good. All right. As you can see, as the older you get, the brain starts to shrink here, which allows more space. What you're seeing is a subdural hammer. This is actually a bleed, what you're seeing in here. So what happens with that is obviously the skull is still very hardly intact, and it doesn't really have much flexibility with the skull itself. So where's that blood going to go? It's going to push downward into the brain, right? And they're going to start seeing stroke-like symptoms, different changes in mentality from people that are normally very nice and pleasant become very angry, combative, depending on where the bleed is located within the brain and where it's pushing on the brain itself, on which that specific hemisphere to a specific lobe or where the damage is actually located. You'll have some sensory changes as well. So most older adults can see and hear well, but some may need eyeglasses or hearing aids. Do not assume that older patients are deaf and nearly blind, okay? Don't start screaming into their ear. They say, can you speak up for me? Then speak up. Speak slower so they have an opportunity to read your lips if they have a hard time hearing. Pupillary reaction and ocular movements become more restricted with age. The pupils are generally smaller, right? So don't start just pushing Narcan on people that have small pupils, okay? They may not be on any opiates at all. The opacity of the eye's lens diminish visual acuity and makes pupils more sluggish from responding to light. Visual distortions are also very common with this, along with hearing loss is 4 times more common than vision loss. You're like, hey, what? And you have to kind of slow down, speak clearly, and let them hear what you are saying. Some psychosocial changes increase the number of older adults in the United States as the result of the baby boom of the 1940s to 1960s has produced a need for more assisted living facilities. Right? Disease transmission in these environments may be particularly problematic during times of the pandemic, like influenza or COVID-19, and financial limits may restrict the access to healthcare and medications. We see a lot of that now. And one of the things you see, depending on certain areas, is a lot of patients wait till the last second to call, and the next thing you know, it's too late, right? So they wait until they're actually very, very sick before they call 911 because they don't have health insurance or the ability to pay. Some other psychosocial changes would be in five years preceding death, mental function is usually presumed to decline. With that, older adults face the issues of mortality, and with good resources and support, older adults in their 80s and beyond can enjoy life and start feeling productive. All right, turn this off really quick.
This conference will now be recorded.
All right, so we're going to cover chapter 12, which is the principles of pharmacology. So a lot of this stuff is going to be review in regards to the EMT level, but now we're going to cover a little bit more in depth on terminology, how medication names work, how drugs are manufactured, how we store medications, our scope of practice, how we follow certain medications as well, looking at how the drug affects the different systems, from the sympathetic system to the parasympathetic nervous system. We'll cover more of the analgesics and different stimulants now that are out there and whatnot. So this presentation is a little bit longer, but we'll definitely get through all this for you guys tonight, and hopes to be out before like 9:30 or so. We should be able to get through this. All right, so let's get started with principles of pharmacology. There we go. So we're going to cover more of the medication safety, kinds of medications used during a drug emergency, medication legislation, the naming of meds, classifications of the medications, then storage and security. We're going to look at metabolism and how they excrete, the mechanism of action, the autonomic pharmacology behind it, the medication response and relationships, medication interactions, and then toxicity. So there's a lot of different things we need to understand about the medications that we give. We don't just follow the cookbook and say, we're going to push this because the protocol says so. We do follow our protocols, but I want you guys to have an understanding of what is actually going on in the body. Because what have I always told you guys since the beginning in regards to anything that we do? There's always what? What is always something we do? If we give something, something happens.
Cause and effect?
Cause and effect, right? Perfect. That's something you should never forget. Anything that we do with a medication like this has a cause and an effect of what we do. This is what's going to happen. This is the effect. And that effect may make something worse, but also make something better. Then we got to treat that next effect with a different medication to counteract what we did with the medication that we just gave, right? So there's a lot of different things behind that process we have to look for, right? So you just got to be careful in what you administer, what you expect to see happen when you give this, and what's happening at the cellular level to make these medications work. So AEMTs can administer certain medications to patients and also help patients self-administer other meds, right? So with that, we look at different drug profiles, which gives all the specifics about a medication, right? So that's going to be very important for us to understand the ins and outs of every med that we do. So on table 12.1 in your books, there lists components of a drug profile, which lists listed in various pharmaceutical publications. So let's go over some terminology. Pharmacology is a study of properties and effects of a drug and medication on the body. A drug is a chemical agent in a diagnosis, treatment, and a prevention of a disease, where medications are the chemical substance used to treat or prevent a disease or relieve pain. The dose is the amount of medication that is given. And the action is the therapeutic effect or intended effect that medication is expected to have on the body. All right. The unintended effects that are undesirable but pose little risk to the patient. An untoward effect is the effect that can be harmful to a patient. And then toxicity is the risk that a substance will pose a health hazard to an individual or organism. So we'll go more in depth in this in a little bit. Indications are used as therapeutic uses for a particular med, why we give it. And then contraindications are times where we should not be giving a patient medication. And with this, it would be when a patient would be harmed but have no positive effect on a patient's condition. So one of the things people may say to you is, I'm allergic to epinephrine.
I'm not sure I understand.
That was weird. All right, apparently Siri had something she wanted to say to me. That you may say, I'm allergic to epinephrine. Well, can you be allergic to epinephrine? Really? No, because your body naturally makes it. So you're not allergic to it. Usually when they say that, oh, it makes my heart race. Well, that's a sympathomimetic effect behind it. So yeah, it's going to make the heart race. Right, so you have to know when indications, contraindications, the therapeutic effects, the drug dose, time, the mechanism of action, how it works. So understanding the terminology will help with this. So medication names or drugs we use are derived from 4 principal sources. 1 is animals, 2 is a vegetable or a plant source, 3 is a mineral, and 4 is a synthetic compound. So one synthetic compound that is made is fentanyl. Fentanyl is not natural, but morphine is. So fentanyl has a synthetic compound. We also have trade names. So trade names are a brand name a manufacturer will give to a medication. Proper nouns that begin with a capital letter as well. And then medications may also have many different trade names depending on how many companies manufactured it. Okay, one of them being like metoprolol is no different than Lopressor. It's the same medication. Solumedrol and methylprednisolone. Dexamethasone, which is also used as a steroid as well, a corticosteroid. But dexamethasone, another name for that is Decadron, right? I'm trying to think of some, I'm drawing a blank, other ones that are out there. So those are some medications that have different names versus trade name versus a generic name. So a generic name is the original chemical name of a medication, usually the original medical name of a med. Usually suggests by the first manufacturer and approved by the FDA. All medications licensed for the use in the United States are listed by their generic name in the USP, which is the United States Pharmacopoeia. A chemical name is a precise description of medications, chemical composition, and molecular structure. So the official name is a name assigned by the medication to the medication by the USP, which is usually the generic name followed USP next to it. All right. So here's some examples. And I'm not sure why they gave you guys this as an example, but they did. So the example of various names for one drug, a chemical name, as you can see, is very long versus a generic name. So looks like biclomethazone, but the trade name is Vanseril, and the official name, as you can see, is the same thing as the generic name with USP next to it. This is all the same drug. All 4 of these is the same medication. A lot of times what we'll end up seeing is either the trade name or the generic or the official on bottles and vials, things like that. So have an understanding of the different names that are there, because you may have to give something. Another one, okay, I'll give you, here's one for you guys too that you can administer. Ondansetron. Ondansetron is the same thing as Zofran, right? So 2 different names. Another one is like Reglan and metoclopramide. 2 different names, same medication. Ketorolac and Toradol, same medication. Now they're starting to come to me now. Prescription medications are usually distributed by pharmacists according to a physician's order. And then OTC is over-the-counter medications which may be purchased directly without a prescription. We'll cover more of over-the-counter medications when we start talking about toxicology and things that over-the-counter medications can do if taken in large doses as well. Or even household cooking products that can also do the same thing. The US FDA, Center for Drug Evaluation and Research, are different references you can utilize. The Physician's Desk Reference, or the PDR. The hospital formulary as well. Drug inserts, the internet. I personally use Hippocrates on my phone, which is a free app that has all the different medications. But I also have a drip reference guide, which I pay $50 for. But that's more for interfacility transfer than I do as a medic. But the Hippocrates app is something that every provider should have on their phone to look up different medications. It also has a pill identification feature as well. So all you have is scores, numbers, and shapes and color. It'll help you break down the medication you potentially could come in contact, or potentially the patient overdosed on, or things like that. AEMTs should be familiar with these resources and field references, particularly regarding medications encountered in the pre-hospital setting. Every medication that you can administer as an advanced EMT, you should know the ins and outs of every med, right? And have the understanding of what works, what's going on within the body. So the US Regulation of Pharmaceuticals, manufacture of pharmaceuticals in the United States and most other countries is subject to a variety of laws and regulations. Let me go over some of those now. They have to be intended to protect consumers, prohibit manufacturers from making false claims about the benefits of the drug, prohibit companies from advising patients on administration of the drug, require manufacturers to publish information about side effects and known potential harmful effects, outline standards for drug manufacturers to ensure the drug produced by different manufacturers are uniform in strength and purity. And they also have standards that are published in the USP and National Formulary, which are several federal laws that are enacted to protect patients from unsafe substances as well. So with all this being said, medications don't just come to the plate without being approved, which is why it's taken so long, because especially for a medication that you could administer as an advanced EMT in New Hampshire is a gas called nitrous oxide. Nitrous oxide had to be nitrous and oxygen with a mixer that went into a regulator to be able to administer the medication. For the longest time, the FDA never actually approved a pre-mixed bottle of nitrous and oxygen. They have now since, and Vermont actually brought it into their formulary of medications for the advanced level. So that is up there, and it's making its way down towards us in New Hampshire and Maine as well. So it's just another option of medications that can be administered if your state protocol allows you to do so. And since this is a New Hampshire class,
Hey Kevin, Nitronox is used for pain, right?
Correct. Only orthopedic pain though. So abdominal pain, chest pain, no gases. Because if there is actually an organ or that's inside that's damaged, the last thing we want to do is put more gas into it. So I'll get back to you, Mike, in a second. I saw yours as well. So it's only used for orthopedic pain only. So fractures, broken bones, things like that. And there is no specific dose to give. You just give them basically you just give them the mask, they inhale until they pass out. Pretty much how it works. So Mike, you asked, does it work without signal? Yes, it does. Yeah, pregnant women, we don't want to give pregnant women nitrous oxide. At least you know the fetus would be happy though, if you did. All right. Next slide here. So the Pure Food and Drug Act of 1906 is the first federal drug-related legislation in the United States, which protects public from food, medications, and alcoholic beverages that may be mislabeled, poisonous, or otherwise harmful. The Food, Drug, and Cosmetic Act of 1938, which was amended in 1952 and 1962, required drug makers to label their products indicating whether they contain potentially habit-forming substances and to include warning about possible side effects. This was authorized creation of the FDA. It also mandated that dangerous drugs could be dispensed prescription. The Harrison Narcotic Act of 1914 regulated important manufacture, prescription, and sale of several non-narcotic drugs and cocaine, opium, and their derivatives. So back then, you could actually, it was regulated that you could purchase cocaine and opium. As you can see, a lot of that's changed over time. Required precise record keeping about dispensing of controlled drugs. Required registration of distributors such as pharmacists. Also, illegal possession or distribution of controlled drug or drugs could result in fines and imprisonment. The Narcotic Control Act of 1956 increased penalties for violation of the Harrison Narcotic Act, which made possession of heroin illegal and outlawed acquisition and transportation of marijuana, because you could not transport it or acquire it. But then, in 1970, came the Controlled Substances Act, which is a comprehensive legislation dealing with narcotic and non-narcotic drugs that have potential for abuse. So specific requirements for registration, procurement, storage, distribution, record keeping for the drugs, penalties for failure to comply with requirements. And with this as well, drugs are classified into 5 categories, or what they call schedules, right, according to their abuse potential. So we have Schedule 1 drugs, which have the highest abuse potential and a propensity for severe drug dependence. And that goes to a Schedule 5, which includes drugs to the lowest abuse potential. So if you look at Table 12.3 in your books, this lists the different schedules, including descriptions and examples. So be aware of the laws in your state and always follow your local protocol. Please do not go outside what your protocols tell you to do so. The manufacturing related regulations, which are federal regulations, also focus on guaranteeing standardization of dosaging. So standardization assures patients when they take a medication with a stated amount of the active ingredient that they will receive from the amount of drug that they take. So for a drug to carry a USP label, the amount of active ingredients must be within 95 to 105% of that stated that's on that current label. All right. Government agencies that regulate drugs are the FDA, which enforces Food, Drug, and Cosmetic Act, determines safety and efficiency of a drug before they are allowed to enter the U.S. market. Okay. So again, like I mentioned before, even with all this COVID stuff, they had to get emergency FDA approval in order to put medications out into the world or the U.S. for us to be allowed to use them. Also holds the regulatory oversight authority regarding the safety and effectiveness of vaccines utilized in the United States. The DEA executes provisions of the Controlled Substances Act, which includes registration of physicians who are permitted to dispense controlled substances. The FTC monitors drug advertising to ensure it is not misleading or inappropriate, right? Which then makes recommendations to the FDA regarding the direct-to-customer DTC advertisements. So I'm sure that you guys have seen on television, you see the new medications that get released and whatnot. If they fail to mention something within that commercial, and a person ends up with a symptom of that or a diagnosis, let's say cancer, for example, all right? Then you start noticing all the medical or the legal stuff pops up on TV now saying, if you've taken this, you're entitled to compensation, because they found that they didn't advertise this correctly. Patients then obtained a disease of some sort or a medical issue with that, which then in turn caused a massive lawsuit towards the company. Now people are then allowed to obtain money through a lawsuit. So as you can see, it's a big round circle. This is why the FTC, the DTC stuff, and the FDA all work together to make sure that that doesn't happen. So false advertisement isn't going out. That's what all that is there for. So the drug approval process for any new drug, commercialization process takes years. Okay, now keep in mind, I say it takes years. The average time for a drug to be developed, tested, and approved is about 9 years. As we all know, COVID so it takes about 9 years, but at certain times of mass issues like we had with COVID-19, as you notice, the FDA approved things a lot faster. In some cases, manufacturers spend almost about 9 years developing a drug to find out the drug dose does not work as envisioned, or it is too dangerous for human consumption. So all new drugs must go through animal studies and clinical trials in humans before approval for distribution. So humans can do the trials, but they have to sign waivers of liability in order for that to happen. Animal studies are designed to learn more about the properties of the drug and identify tissues and organs that are sensitive to the actions of that drug. So testing in at least 2 animal species is required by law. So after successful completion of animal studies, an investigational new drug may enter clinical trials in humans at that point. So it does take some time. There are different clinical trial phases. Phase 1 being the new drug is tested in healthy volunteers to compare human data with those in animals. This determines safe dosages and assess the safety of the medication. Once that is completed, it goes into phase 2, which is performed in homogeneous populations of patients between 50 and 300 patients. In a double-blind study, one group receives a drug and the other group receives a placebo. So it could be sugar water, for example, or just water alone, or saline. This is designed to evaluate efficacy and safety of the medication. It also established which form is most effective. Then we go into phase 3, where a drug is made available into a larger group of patients, several thousand, where studies last several years to evaluate the efficacy and monitor the nature and incident of the side effects. Once all that is done, we go into phase 4, where they apply for the FDA to approve the drug to market. They compare the new drug with others that are currently on the market and examine cost effectiveness and long-term efficacy. So there's a long process just to get medications out there for the most part, unless it's something in an emergency type situation. So as far as storage goes, and the security of controlled substances and drug storage, drug containers or boxes should be guarded against possible theft. So this requires boxes to be locked, secured within the ambulance. The policy should guide the manner in which the drugs are secured, stored, distributed, and accounted for. So if a controlled substance, such as a narcotic, are administered, records must be kept separate from other paperwork. All right, separate narcotic forms. The DEA strictly regulates these substances, and if the drugs are lost or stolen, the supervisor and law enforcement personnel must be notified immediately. All medications should be stored in a temperature-controlled environment, which means you do not leave your ambulance outside for the night with your medications inside of it. If they get too cold, they can damage the medication, or too hot. Medications have to be temperature-controlled. The potency of medications affected by temperature. One of them being nitroglycerin. That's why you find nitroglycerin, whether it be in a liquid form for medics or if it's in a tablet form, which you guys could administer sublingual. If you notice that nitroglycerin is in a dark, light restricted bottle, is because light cannot hit that nitro because it actually loses its effectiveness to that medication. Moisture, shelf life, exposed to air as well are all different things that the potency of the medication can be affected by. Expired controlled medications must be destroyed. So destruction must be witnessed by 2 employees and or documented on proper forms. So again, if you are an AEMT, you're not going to be handling anything with narcotics anyways, all right? You guys don't destroy it. You don't sign as witnesses of waste, right? None of that can happen. So you don't have to worry about that part of it. But other medications that you do administer, right, those ones there have to be disposed of appropriately. Not just tossed into a trash can. Every ER that you go to does have a pill disposal box. It looks like a sharps container, but it has a kind of like a black top on top, and you put the medication in. It all goes into one big pile inside it. They put liquids inside of that as well to dissolve those medications that are in there. So let's talk a little bit about pregnant patients. Stand by one second. I just got to plug in my computer really quick. Battery's almost dead here. All right. So pregnant patients. Before administering medications to a female of childbearing age, you need to ask the patient whether she could be possibly pregnant. And you have to be honest with them. Say, listen, if you are pregnant and we give you this medication, it could cause more harm. We need to be honest. You need to tell me if you are or not. Right? Expected benefits should be considered against the possible risk of the fetus. Prescription over-the-counter drugs do have potential to harm the fetus or the newborn, okay? This is where programs like Hippocrates, or even using your internet-based stuff like Google, and look things up before you start giving meds, right? Especially if they're taking some from home, they start developing pain, right? Severe abdominal pain. And they know they're pregnant. Have you started any new medicine regimens? And look them up. So teratogenic drugs are a drug that poses a risk to the normal development or health of an unborn fetus. So changes in a pregnant woman's body affects the way drugs are also processed and may increase chance of harm. Right? Metabolism of the drug in the liver is decreased. They have an increased rate of excretion as well because now they have another child inside. The FDA has removed the scale with categories A, B, C, D, and X to indicate drugs that have documented problems in animals or human during pregnancy. They've removed those scales. So like when I went through medic school many, many years ago, we talked about A, B, C, and D, and X medications based upon what schedule they were, and they put down schedule 1, A, B, C, or D, or X within that. They've now replaced that with a more detailed system that uses narrative summaries to convey prescribing information related to pregnancy, including labor and delivery, lactation, and risks of the medication to male and female users with reproductive potential. So instead of doing A, B, C, D, and X, now they've gone in more narrative form as well. So yes, Mike, I will be getting you guys that as well. on all the medications utilized for the New Hampshire protocol. So you'll get the ones, so for everybody, you're going to get the medications that are approved through the National Registry you need to learn for testing purposes. And because this is a New Hampshire class, there's a scope of module practice as well. So you're going to get the additional medications that New Hampshire allows you to. So Kenny, I think you're the only one that's doing main EMS, if I remember correctly. Most everybody else is doing either Massachusetts or New Hampshire. So I will make sure that I go through the protocols with you on a practical day as well. So there we don't confuse New Hampshire scope of practice with Maine. But I have to teach you guys the scope of practice for New Hampshire stuff, including you, Kenny, as well, because this is a New Hampshire class. But we'll make sure we cover the differences as well. And then I'm not sure if Jen is on, and for Matt Harrington, I know you guys are primarily going to be working in Massachusetts as A's. So we'll kind of cover what their scope of practice is, but I don't want to do that in this setting, as this is a New Hampshire class. All right, but we will cover those in person, so that way you don't confuse the difference. But you do have to memorize the ones that are at the national level. Those are required.
Wait a minute, you mean in Mass we actually do have a scope of practice?
Yeah, you can show up. No, I'll go over that kind of stuff with you. I'll go over that with you as well, Matt, for Mass scope of practice for A's. But a lot of stuff down there, though, as you know, is all medical control approved. So it makes things a little bit different.
Okay.
But in the meantime, we're focusing on New Hampshire and National Registry. All right. So medications approved after June of 2015 have only the narrative summary. Anything prior to that still has some of the old stuff there. So table 12.4 outlines the drug categories for pregnant women. I'm trying to go back to this stuff here. So as they're listed in the chapter, Tandra, so if you guys download the app for New Hampshire, Maine, New Hampshire, Mass, Vermont, I don't want any state you want. It's called PPP, which is Paramedic Protocol Provider. That app, I don't know if it's like $10, I think it is, something like that, $5 or $10. It has every state's protocols in it, and it stays updated when there's an update within the state. That's what I use. So I would recommend, I cannot force you to download that app, but I would recommend that you do get that, especially if you're practicing as an A, to look at the protocols for the state that you're riding in. And it kind of breaks down too. It's like Matt O'Connor said, there's a breakdown in the back of the protocols as well. And the New Hampshire protocols breaks down every medication that's there. So it does help out based on license level. So again, we will cover all that stuff later on. Actually, since we're on it. Did you send that out to everybody or just to me? Just me, okay. JT just sent me the medication list for AEMTs. Yeah, I'll take a look at it. So I'll email that out to you guys as well. But I would definitely download the Paramedic Protocol Provider app that has all the different states you potentially could be working in with protocols. Maine EMS, I think, has their own one that you can download still as well. I haven't used that one in a while. They do. Awesome. Thanks, Kenny. Yeah, okay. But New Hampshire does not have one. They'd make you download like the PDF version or something like that. So I'm trying to update that now too as well, so I can kind of go over that with you guys. All right. So as far as many drugs, they still use, many drugs used with unknown effects during pregnancy are still used. Many of the drugs out there still use or have the unknown effects during pregnancy. Delayed pharmacologic treatments for pregnant patients until they reach the hospital, except in life-threatening situations. So again, if they need something and it's going to mean life or death, we give it to them. Epinephrine, okay, by the way, is not is okay. I should say is okay to administer for cardiac arrest in pregnant women. Just keep that kind of stuff in mind as well. Trying to bring up that New Hampshire one on my iPad here so I can kind of go over some of the stuff with you guys as well during the class. All right, continue on. So again, when in doubt, contact med control, right? Med control is a great tool to utilize. Call them, have a conversation with them on the phone. Make sure that it's okay. Have a consultation with them. You know, go over stuff with them. I'm just trying to bring up that protocol. It just told me I couldn't download it for a minute there. I'm not sure why. All right. As far as pediatric patients go, medications have different effects in children. Young infants have reduced metabolic capacity. So also have incomplete development of the GI tract, which then slows absorption of the oral medications and delays elimination. So they can stay in the body longer, right? So you need to understand what they call pharmacokinetics. So pharmacokinetics of the medication and how long it stays within the system. Epinephrine stays in your system around 3 to 5 minutes. That's why we give it every 3 to 5 minutes. There are medications at the paramedic level, like for one being like amiodarone, which has a half-life on the pharmacokinetic of 40 days. It stays in your system. All right, just trying to locate the medication list so we can kind of go over that here. Let's see. I don't remember where it is in the New Hampshire protocols with the list breakdown, but there somewhere. I'll find it in a little bit. All right. So geriatric patients, so changes in pharmacokinetics in geriatric patients are comparable to those in young children. Hepatic function, GI activity starts slowing down and delays the absorption and elimination. So often remember, they often take several medications. So if they see 5 different physicians and the 5 different physicians don't review all the medications that they take and give, here, take this one, here, take this one, here, take this one. But medication 1 and medication 3 reacts to medication 2, causing this side effect. Next thing you know, they're on 15 different medications to fix the side effects of that one versus the next one versus the next one. When all reality is, do they really need to be on 15 meds, or can they really only take 2 because of all the different side effects that happen, and they're taking different things to kind of offset the side effects from the other med, right? So that's something as well. That's something that we need to figure out. But something to take note of. So often taking several meds may unintentionally overdose on particular drugs or forget to take it. So a lot of times that can happen as well, which is why it's always good to have the Sunday through Saturday drug locker so they don't mess up the medications, right? So your scope of practice, you are legally, morally, and ethically responsible for each drug that you administer, right? That's why I said you need to know the medications you give. Drug administration must be safe and therapeutically effective. We don't just give medications because the protocols say to do so. We give medications to get a therapeutic effect behind it. And why are we giving it? Have a cause and effect justification of why we do things. Always keep the field guide or other references handy, right? Follow the standardized national guidelines listed in Table 12.5 when providing drug therapy. So methods of drug classification, they're based on the effect drugs will have on a particular part of the body or a specific condition. Many fall into more than one category. They're classified into 3 different categories: body system, class of an agent, and mechanism of action. Right? So when they look for the body system, which body system does it attack? Is it cardiovascular? Okay, so I'm going to give a patient, let's say metoprolol. We know that metoprolol is a beta blocker, which then slows down and reduces blood pressure, right? So that's kind of the mechanism of action, how that works, without getting into the paramedic lecture behind beta blockers, right? So with that being said, we know that it affects cardiovascular, but it's a beta blocker's mechanism of action, but falls under, I'm drawing a blank of the class right now. I can't think of it. It's on antiarrhythmic. I'm drawing a blank. I can't think of it. If anybody else knows the class of metoprolol, let me know. I just can't think of it right now. But we can use, let's go to one you guys can get. How about nitro? Nitro has an effect on the body system, right? It's cardiovascular. The mechanism of action is vasodilation, right? So it's a vasodilator, which falls into cardiovascular, which also falls into a class called nitrates. So there are 3 different things. Then you have albuterol, which is respiratory system. Mechanism of action is a bronchodilator, but the class is a sympathomimetic because it mimics the sympathetic nervous system, increasing heart rate. So with that, it has different effects, like, for example, beta 1 and beta 2 receptor effects. So it has beta 1 effects, so it increases heart rate, and beta 2 effects, because you have 2 lungs, beta 2, which then affects the lungs. So the law behind the mechanism of action and how these medications actually do work. So the nervous system classifications. The body principles control system. So this is composed of central nervous system and peripheral nervous system. So the central nervous system is the brain, spinal cord, and peripheral nervous system is all nervous tissue outside the CNS, outside your main canal that you have, your spinal cord, the brain. The peripheral nervous system contains autonomic nervous systems, what they call ANS. This controls the automatic and voluntary functions, and it is divided into 2 systems, the sympathetic and parasympathetic nervous system. So the sympathetic nervous system is responsible for the body's response to shock or stress, what they call fight or flight. So if I walk up to Matt Harrington and I smack him across the face, he's either going to fight me or he's going to turn and he's going to run away. Sorry, Matt, I didn't mean to pick on you.
I'll just kick you in the nuts and run away.
So that's the sympathetic nervous system kicking in that fight or flight response. And when that happens, adrenergic response ultimately causes release of hormones like epinephrine and norepinephrine, which, by the way, are the neurotransmitter of the sympathetic nervous system, is epi and norepi, including shunting of the blood from the extremities to the vital core organs, increasing the heart rate and respirations, increasing blood pressure, dilation of pupils, and reduction of the digestive system activity. He is ready to fight, or he's ready to run away. The parasympathetic nervous system relaxes the body, controls autonomic functions during non-stressful times. It's called the rest and digest. What used to be called feed or breathe, they changed the name now to rest and digest. And it's opposite the sympathetic nervous system, completely opposite. So let's get more into the adrenergic receptors, which then cause a response on target organs. So there are hormones are then released by sympathetic system stimulation, causing intended effects by acting on hormone receptors. Adrenergic receptors then cause a response in the target organ, generally divided into 4 types: alpha 1, alpha 2, beta 1, and beta 2. Right? Anything that has to do with alpha has to do with vasculature. Okay? The vasculature of the body. Right? So if we're dilating or constricting blood vessels, that's going to be an alpha response. What medication do we administer that can dilate blood vessels?
Nitro.
Nitro can dilate blood vessels. What medications do we administer that constrict blood vessels? Right? Matt O'Connor said epi. Everybody else agree with that? Yes, yes. I should be hearing yeses all over. Epinephrine, right? Does epinephrine also have a beta 1 and beta 2 effect? Beta 1 has to do with rate control. Beta 2 has to do with the lungs, okay? So does epinephrine have alpha effects and beta effects? It does, right? Because it helps with bronchodilation, constriction of vessels. On top of that, it also has heart rate effects by increasing heart rate. All right? This is more of a breakdown than things that you learn in EMT school. This is getting into the advanced level of care now, where we have to have an idea of what we're giving, why it's doing it, and is there going to be or what the effect is going to be based on the cause of what we're treating. Right? So drugs affecting the sympathetic nervous system are called sympathomimetics. Sympatho being the sympathetic system, mimetic means mimicking that system, which is producing as a hormone of the sympathetic nervous system, what they call sympatholytics. Sympatholytics inhibit the sympathetic nervous system. Another name for that is called anti-adrenergics. So anti-adrenergics is like sympatholytics, which is like sympathomimetics. Have I lost anybody yet with that? No? Matt, you got this? Everybody else good? Yes? Do I need to spend more time on this?
I got it.
All good? All good? I like it. So remember, drugs affecting sympathetic nervous system are called sympathomimetics. Sympathomimetics being albuterol being one of them that we can administer at the A level. Right? Sympatholytics inhibit that system, also called anti-adrenergics. Antagonists counteract the actions of something else. Agonists bind to a receptor and cause a response. Give me a medication that binds to a receptor and causes a response. Okay, I'm seeing naloxone or Narcan. Perfect. Good, good. All right, I like it. Beta blockers. Here's a secret. Anything that ends in OLOL is a beta blocker. Any medication. Any medication that ends in OLOL is a beta blocker. Everybody got that? Remember the OLOL. OLOL is beta blocker. Anything that ends with PRIL, PRIL, is an ACE inhibitor. Okay? ACE inhibitor. Here's one for you guys, some extra credit for you. What does ACE stand for? ACE. Anybody know that one? If I give it a shot, anybody? All right, I'm guessing no. No one wants to give it a shot. So it's called an angiotensin converting enzyme inhibitor. Look at that, Mike. You got it. Did you look that up, or do you know what it was? Listen, there's nothing wrong with using Google. Medic school. I like it. Angiotensin converting enzyme. And specifically more in the conversion of angiotensin 1 to angiotensin 2 in the system, in the renin-angiotensin system. All right, so moving forward, not going to get too in depth with that yet. Some medications stimulate alpha and beta receptors, whereas others are selective to specific receptors. Beta blockers are used to control blood pressure in some patients, a heart rhythm disturbance in others. So you administer drugs that antagonize the beta-1 receptor to treat cardiac arrest and hypotension, right? Beta-2 selective drugs use bronchodilation with little effect on the heart. But if you use albuterol, which is a sympathomimetic, you're going to have beta-1 effects because it does increase that heart rate, but also is selective to utilizing bronchodilation as well. All right, moving forward, let's go to the next one. Drugs that affect the parasympathetic nervous system. Parasympathomimetics are agonists to the parasympathetic nervous system, also called cholinergic medications. I will go over anticholinergic and cholinergic syndrome with you guys in toxicology. I'm not going to cover it now. All right, but they may act directly or indirectly on cholinergic receptors. So if excessive cholinergics are present, they may exhibit sludgium symptoms. So who wants to tell me what sludgium stands for? It might be easier if someone unmutes and actually tells me. What does sludgium stand for? We just covered this the other day. Have I lost anybody? Rosa, you give it a shot?
True, sludgium. Isn't that from when we have poison? So
Yep.
salivation. Oh God, it's like urination. I don't know what the L is.
Lacrimation.
Lacrimation, urination, defecation. The GI. I don't remember the other two. Something like muscle twitches.
E. Yeah. E. Muscle twitching, muscle twitching and myosis. And E is emesis.
Okay.
Good job. Awesome.
Ugh.
So patients exposed to certain fertilizers, insecticides, VX gases, and sarin gases exhibit sludgium symptoms. All right, so parasympatholytics is an antagonist to the parasympathetic nervous system. One medication commonly used is atropine, which is also called an anticholinergic medication because they block two types of cholinergic receptors. Analgesics are medications that relieve pain, to include analgesia, and what we have are what they call opiate agonists. The most common class of medication used for analgesia is opiates. Similar or derived from the opium plant, they bind to opiate receptors, which prevent neurons from sending pain signals. This is also a CNS depressant. A fast-acting, rapid-acting medication that is very potent would be fentanyl. Another name for fentanyl is called sublimase, which has a relatively short duration of action. It doesn't last very long, but it works very well. It's 100 times more potent than morphine. Fentanyl is 100 times more potent. All right. But dilaudid, giving 1 milligram of dilaudid is like equivalent to giving somebody like 100 milligrams of morphine, type, not 100 milligrams, wow, 10 milligrams of morphine, right? That's why it's so important when medics administer medications, they understand what the effects are going to be giving and how it works on a patient, right? So again, a lot involved there. But again, we can still treat pain at the advanced level. We just don't have that ability to treat it with analgesics. We can use Tylenol, ibuprofen, PO, and I'm hoping in the next protocol change, you guys will get Toradol. So non-opioid agonists may have the antipyretic properties, which can reduce fever. All of them alter production of the prostaglandins and cyclooxygenase, which is COX. There are 3 forms, right? One of them being aspirin, which aspirin targets the COX-1 enzymes to reduce platelet aggregation. Another name for aspirin will also be antipyretic, or it also could be a platelet aggregator. It makes platelets less sticky in the system. I don't disagree, Mike. Maine EMS has given IV Tylenol to advanced level. So I would assume IV Tylenol is supposed to be rolled out in the next protocol rollout for New Hampshire, and I think they're probably going to do for advanced and medics. Because Maine EMS already has it for the AEMT and medic level already. So you also have what they call NSAIDs, which are non-steroidal anti-inflammatory drug. An example would be ibuprofen. We have the ability to administer ibuprofen at the EMT level, PO, 400 milligrams. This reduces pain, inflammation, and fever. It also inhibits COX enzymes as well. Another NSAID that's also very good medication that I'm hoping comes out is the Toradol or the Ketorolac, which is an IV high-powered NSAID, which works really well for pain and even better for renal colic or kidney stones. Some examples of the para-aminophenyl derivatives would be acetaminophen or Tylenol, which is another one we can utilize, and you can give up to 1,000 milligrams PO at the advanced level or the EMT level. Opioid antagonists reverse the effects of opioid drugs, like naloxone or Narcan. Opioid antagonists have an agonistic and antagonistic properties, which then decrease the pain but do not diminish function of the respiratory system or result in dependence or addiction. All right, anxiety sedative and hypnotic drugs. So this helps the patient sleep through a medical procedure by producing sedation and hypnosis, which include benzodiazepines, most commonly used to prepare patients for invasive procedures. Other ones we look at would be barbiturates, opioid agonists, non-barbiturate hypnotics, and dissociative anesthetic agents. Anticonvulsants are used to treat seizures. So believed to be working on inhibiting the influx of sodium into the cells, which then decreases cell capability to depolarize and propagate seizures. So some other anticonvulsants that are out there would be like Keppra being one of them. Patients that take Keppra at home. So again, if they're having seizures and they've had a history of, find out if they've been taking their medications. Keep in mind that overdosing on certain medications can also cause seizures to happen. And seizures may not just be from a neuron issue in the brain. It could also be from an impact. It could also be from withdrawals. withdrawing from alcoholism, things like that, and DTs. Okay. It can also happen from a lack of magnesium, like in pregnancy with eclamptic patients. So seizures can happen. So look for the anticonvulsants and look at history. Stimulants exert action by excitation of the central nervous system, which then increase excitatory neurotransmitters, or decrease inhibitory neurotransmitters. Examples of this would be like caffeine and cocaine, and prescription and illicit amphetamines. So we're going to cover more of this stuff in toxicology too, as well. We'll get more in depth in all this. This is kind of more of an overview. So increase release of dopamine and norepinephrine into the wakefulness and awareness. They increase tachycardia and hypertension. They can cause seizures and psychosis. And high doses can also cause increased nervousness, irritability, tremors, and headache. Some people also experience withdrawal symptoms when they stop taking stimulants that they've been on as well. So I'm going to assume that everybody in the class, you guys are all caffeine addicts, coffee addicts, and all that kind of stuff. I'm good. No, guilty as charged, right? Right, Red Bull. What would happen if I were to say this? Let's say we did a study in the class. This is not going to happen if somebody will tell me go pound sand, right? Right. What if I told you guys you couldn't have caffeine for a week? No caffeine, only water. No soda, no Red Bulls. Screw you.
Oh, my body may definitely have some type of withdrawal.
Absolutely, right? Withdrawal symptoms, and that can happen. Cat hiss, I love it. Seizures, right? Because we live off that, especially in the job that we do in EMS. We live off caffeine. That's what keeps us awake, keeps us functioning. Coffee in the morning. But if you stopped all that and went just strictly to water, water only, no sugars, no juices, water strictly, that's it. Okay? Your body would cleanse, but you'd also withdraw at the same time, where you're going to say, I need to have that one caffeine drink, and you're going to go for it, right? It's the same thing that's happening with patients that are alcoholics. They can't just stop cold turkey because they start going through DTs and withdrawal symptoms, right? So they're off that stimulant. They're no longer taking the medications, or they're no longer taking the drinks like caffeine, right? Now, alcohol is not a stimulant, but they stop taking that and their body depends on it. All right, then they go through withdrawal symptoms. You can do the same thing if you stop caffeine cold turkey. You got to wean yourself off. It's like that with medications, the same thing. All right. So again, very important to pay attention to and ask the patient about their history. Very important. All right. Depressants slow brain activity. May be present and prescribed to treat anxiety, muscle tension, pain, insomnia, stress, panic attacks, and seizures. And some are used as anesthetics, like lorazepam, which is Ativan, diazepam, Valium, alprazolam, which is Xanax, or zolpidem titrate, which is Ambien. All medications that can be used to slow the system down, right? So if you had a patient that overdosed on this, what would you expect? What would you expect if someone overdosed? Matt, you should know the answer to this one here. Harrington. So we just had a patient like this until she decided to jump in midair and I caught her.
Well, actually, you know what? She was a little confusing because there were some times when she was catatonic, and I mean, I question whether she was. I think she might have been faking to some degree because it seemed like she knew, you know, when she. Seemed like every time she tried to like escape is when she thought we were all distracted.
So would you say that she was maybe taking the medication because she has anxiety and maybe panic attacks. And if she took too much because she was freaking out at home, that caused her to be, not say catatonic, but she became more relaxed. She was kind of that blank stare, and then kind of came out of it, right?
Yeah.
Yeah. So she was on a depressant, this patient that we had was on a depressant that she may have taken too much of, and she's already on quite a bit already a day, all right? So we're talking about a patient that a potential overdose on lithium, right? Lithium being a depressant, tried calming her down, and she's already taking 1,200 milligrams daily. That's a lot of lithium. That's a lot to be taking in a day.
Yeah,
right?
It was what, 600 in the morning and 600 at night?
Exactly. Yeah, 600 twice a day. You know, so with that being said, she was on this medication to help her relax and help, my guess would be panic attacks and anxiety, right? I don't think there's anything else that's on there, but it's also used to treat insomnia. I've also seen a lot of patients in medic school go on lithium or Valium being a big one, because it helps calm them down when you have test anxiety, right? In my medic class, 4 students that were in the class that I took many, many years ago went to their doctors and got prescribed Valium because their anxiety was so high testing that they did horrible on it. So they would pop in some Valium and they'd take their test and they'd pass it with a mid-90 because they got rid of that test anxiety, right? So patients don't have to have a history of anxiety and all this kind of stuff to be put on depressants. It could be a temporary thing while they're in school, but then become addicted. Then they take more and then they, they're overdosing. Right? There's a fine line between therapeutic and toxic with that med. Absolutely there is. Very fine line with that. You're right, Mike. Dangerous stuff. This is why it's so important for us as AEMTs to have a very big understanding on pharmacology and what's actually happening with these meds. And if all else fails, you have Hippocrates on your phone. Everybody should have downloaded it. It's a great app to be utilizing. It's going to help you get through it. All right, so psychotherapeutic drugs blocks dopamine receptors in the brain, okay? The Hippocrates app, Kenny. I'm even going to try to spell it. EPOCRATES, I think. I think that's how you spell it. It's an app that, yes, like the Scholar, exactly. It's an app that can work offline as well, as long as you keep it up to date, best you can. It'll also work offline if you have no service on your phone. This is used to treat illnesses such as schizophrenia and depression, associated with a host of side effects. Some side effects with this would be involuntary movements, tremors, rigidity, muscle contractions, restlessness, and changes in breathing and heart rate. Orthostatic hypotension, so truly check orthostatics, lying down, sitting up, standing. Sedation, sexual dysfunction. And a lot of times depression is often treated with SSRIs, MAOIs, and TCAs. We do not see a lot of tricyclic antidepressant overdoses or even patients that are on TCAs anymore. We're seeing more SSRIs and MAOIs in the field, right? Tricyclics, the biggest treatment for that is going to be calling for a paramedic because we can give sodium bicarb to neutralize the system for that. So again, if you have someone that overdosed on a TCA, that's going to be one of the things, and we'll talk about the SALT acronym with TCAs later, but we'll get into that more towards toxicology. So drug effects affecting the cardiovascular system are classified according to their effects on specialized cells, right? The effects of the heart categorized as the following, whether they're chronotropic, which affect heart rate, inotropic, which change the force of contraction, and dromotropic, which alter the velocity and conduction of electricity through the heart. They all can be positive or negative effects to the body, right? The other one would be cardiac glycosides, which are derived from plants, right? They block certain ionic pump cell membranes, which indirectly increase calcium concentrations. And those have numerous side effects. One cardiac glycoside medication, right, would be digoxin, right? Digoxin. And we'll cover more of that in toxicology and digoxin and what they call dig toxicity and how we're going to be able to tell. But one of the things, some of the things we're going to look for, the patient will have what they call yellow vision, being one of them. And the other one is going to be more noticed on an EKG, and it's looking for what they call the ice cream scoop, and I will show you guys that later on when we get into cardiology. Antiarrhythmic medications can have a direct and indirect effect on cardiac tissue. A common one that we're going to come in contact with is a calcium channel blocker called diltiazem. So a lot of patients take diltiazem at home to treat atrial fibrillation. Other ones would be classified as the mode of action, like a sodium channel blocker, which slows conduction through the heart through a negative dromotropic effect. Beta blockers reduce adrenergic stimulation of the beta receptors, so we're going to start seeing things slow down, like slow heart rate. Now, a patient that overdoses on beta blockers, the only treatment for that, and it's going to be paramedic level again, is intravenous glucagon, 2 to 4 milligrams at a time. Not many services actually carry that much in their ambulances because glucagon goes for $300 a vial. Potassium channel blockers increase heart's contractibility, which is a positive inotropic effect, and calcium channel blockers, which decrease the force of contraction and automaticity and decrease conduction velocity, utilizing a negative dromotropic effect. The stuff that's in here, paramedics do carry, let's say the antidote to treat this. But it has to be recognized that this happened. You've got to look at the medications they may have taken. If they took too many of them, it could be a calcium channel blocker, potassium channel blocker, a beta blocker, or a sodium channel blocker, right? Now let's talk about antihypertensives, like diuretics. What is one major diuretic that patients take? A lot of patients take these, especially if they have heart failure. Lasix, exactly. And they're not going to call it Lasix, they're going to call it furosemide. And when you ask them, they might tell you, I'm on this water pill. All right, great. So you're on Lasix, furosemide. Remember that furosemide is a non-potassium sparing diuretic that inhibits the ascending loop in the nephron of the kidney, right? Causing you to pee more. This causes the kidneys to remove excess amounts of salt and water out of the body. Also, again, not just taking salt out, that's sodium reduction, but also you're going to lose potassium. It lowers total fluid volume and lowers the preload and increases stroke volume, and decreases stroke volume. Then you have vasodilators, which act on smooth muscles of the arterioles and veins, like nitroglycerin. You have sympathetic blocking agents, including beta blockers and adrenergic inhibitors, like Lopressor, metoprolol, which have diminished effects of the beta stimulation. All right, so rate control. You have angiotensin converting enzymes, or ACE inhibitors, which target renin-angiotensin in the aldosterone system. Right? So this suppresses conversion, like I mentioned earlier, suppresses conversion of angiotensin 1 to angiotensin 2. Right? And then hopes in turn lowers the blood pressure. Calcium channel blockers have an antidysrhythmic and an antihypertensive property. Right? But it's used as an antidysrhythmic. Other antidysrhythmics that are out there would also be like amiodarone. So amiodarone, lidocaine has an antidiuretic property. And remember, lidocaine is a medication that can be administered by the AEMT, but not for the anti-dysrhythmic or antiarrhythmic property, but for the use of numbness when utilizing interosseous access. Anticoagulants, fibrinolytics, and blood components. So antiplatelet agents would interfere with aggregation and collection or platelets as well. So they do not break down aggregated platelets, and they prevent further buildup of the cells. Anticoagulant drugs work against coagulation to prevent the formation of thrombi, which may present in a long-term basis as a preventative measure. You have to be aware of anticoagulant use, particularly when patients have suffered a traumatic injury, and with this can prevent life-saving coagulation needs to prevent blood loss. Fibrinolytic agents dissolve a thrombus and prevent it from breaking off and entering the bloodstream. So let's go back. Fibrinolytics, like heparin being one of them. As far as anticoagulant drugs, give me a couple names of anticoagulants. Okay, what else we got? Other anticoagulants that are out there. Warfarin, yep.
Eliquis.
Coumadin, right? Give me two examples of a diagnosis or a procedure where a patient would be on blood thinners.
AFib, coronary artery disease.
Yep, AFib, and what else?
Coronary artery disease.
And patients that have what procedure done?
Heart transplant.
Or have had what placed inside the arteries?
Pacemaker.
Nope, keep going. Well, pacer can help, but what else? I see Tondra got it.
Would you put somebody on an LVAD?
Possibly.
Blood thinners?
Possibly. Stents. Patients that are on stents. Not on, I shouldn't say on. Patients that have stents in place. So again, questioning. DVTs, that's another one, exactly. Patients get put on blood thinners that had a pulmonary embolus. So there's a lot of different things. They also get put on heparin as well, as a fibrinolytic agent as well with that. Other fibrinolytic agents that also assist with in like STEMI procedure would be like TNK and other things that are given in the ERs as well. All right. So drugs affecting the respiratory system, oxygen, most commonly used medication in the pre-hospital setting, has an inappropriate use and side effects, right? Can we over-oxygenate a patient? Can we give them too much oxygen? Yeah, absolutely we can. That's why they took away the whole, let's get it at 100%. 99, 98, perfectly fine. Don't over-oxygenate a patient. Let's see. Over-the-counter decongestant medications is common during cold and influenza seasons. So patients may take antihistamines during allergy season. People have been known to overdose on a decongestant like pseudoephedrine or an antitussive or antihistamine like diphenhydramine or Benadryl or dexamethasone. So many respiratory emergency treatments also use sympathomimetic medications like stimulation of beta-2 receptors is the most beneficial way for a patient with respiratory emergencies like albuterol, duonems. And xanthines also are a second-line treatment and relieve airway constriction by relaxing smooth muscles of bronchioles and increasing blood flow as well. Or they stimulate the central nervous system. And caffeine is also a well-known medication as well as a CNS stimulant. Corticosteroids also suppress inflammatory response. So caffeine, so patients that are asthmatics, one of the old home remedies used to be, if you're having an asthma attack, drink some coffee. Could help with that stimulation of the CNS stimulant to help with respiratory compromise. Corticosteroids that are out there would be like dexamethasone or Decadron, Solumedrol. You can also use Solucortef as a corticosteroid as well. But again, not at the advanced level. These are the medications that are out there. So drugs affecting the pancreas, variety of hypoglycemic medications that are available out there. So what kind of medications do we have out there for the pancreas? We have insulin, metformin, right? Might just put down metformin, insulin, right? So the medications, so pay attention to the medications that are out there. Patients that are fragile diabetics and that they're actually compliant with what they do, they take a log of their blood sugars, right? They take a log of their scale of insulin and how many units are going to be administering, right? It could be a sliding scale or it could be a consistent number that they give before they eat. A lot of times patients will take their insulin and then forget to eat, and the next thing you know, we're having a diabetic emergency and the blood sugars are high, right? So others alter the way insulin is used in the body. Some act on the pancreas directly. Supplementally increase insulin secretion from the pancreatic beta cells. Insulin sensitivity increased by oral hypoglycemic agents as well. So there's different things that are out there. So again, look at patient medication lists and find out what kind of medications they have that actually affect the pancreas. Other drugs that affect the immunologic system or immunosuppressant medications prescribed by patients who undergo an organ transplant, have an autoimmune disease, or intend to inhibit the body's ability to attack foreign organs like organ transplants, or attack on itself like an autoimmune disease, inhibit the lymphocyte and T cells, or destructive cells that tend to want to fight off the infection, right? Remember, we have killer cells, T cells, all that kind of stuff we talked about during the human body, right? Some vitamins and minerals are necessary substances that allow for normal metabolism, growth and development, cellular function. They may be able to take supplements to replace deficiencies or as a preventative measure. And thiamine is important in the pre-hospital setting. Thiamine aids in the converting of carbohydrates into energy. So people with alcoholism, among others, tend to be deficient in this vitamin, right? So one of the medications that medics used to carry was thiamine. It used to be 100 milligrams intravenous to these patients that had alcoholic issues to help give back that vitamin B12. All right, so that's what thiamine would be for. As far as fluids and electrolytes, we have crystalloid solutions, and they can be isotonic, which is stable medium of administration of medication, and an effective fluid electrolyte replacement. Isotonic, that's what we have, or we carry for isotonic fluid that has effective electrolyte would be what medication? Lactated ringers, awesome. Yep, LR. As far as hypertonic solution, this helps provide nutrition. We do not carry in New Hampshire hypertonic solution. Hypertonic solution is 3%, so it's a higher number, right? And I just listened to a phenomenal podcast on hypertonic solution utilized in sepsis treatment, but also by doing a Lasix challenge with it. So it was actually pretty interesting pretty interesting podcast. The podcast, I'm gonna type it in. It's called Critical Care Scenarios. It's actually a really good podcast. I listen to that all the time. If anybody ever wants to listen to podcasts or not, they're up to 55 different episodes and other different like lightning round stuff that they do. So it's actually pretty cool information. Then we have hypotonic solution, which is beneficial in dehydration situations, but not hypovolemia. And you may also administer other colloid solutions as well. So again, we're going to go over more of this when we start getting into dehydration and more in-depth medications for that. All right, so as far as, well, we're at this point here, we're talking about drugs now, how they're formed. Why don't we take 10 minutes, we'll come back and we'll finish up. We're almost done anyways. So let's just take 10 minutes. I gotta grab some water anyways, I'm starting to lose my voice. So I'll see you guys back at, let's say, 9:05.
This conference will now be recorded.
All right, so to finish off, let's talk about drug forms. So this is a form that a medication comes in, usually determines its route of administration. So this will ensure the proper route of for the medication, timing of its release into the bloodstream, and the effects on the target organs or the body system. So let's go back to something from EMT school, okay? What are the 6 rights of patient administration for medications? What are the 6 rights? Anybody? 6 rights of patient.
Right patient, right route, right dose. Right treatment.
The right route and right time.
Yeah. Right, and the right documentation. Right. And then Mike added one into it too that really never was part of the right to medication administration, though, but makes a lot of sense, is the right to refuse. They can tell you no. They have the right to refuse any treatment that you are offering. You cannot force a treatment on any patient that is alert and oriented. Now, if they're altered, they do not have the right to refuse anything because they are altered, which means you have something called what type of consent? If the patient is altered, what kind of consent do you have? Implied, exactly. Which means that they want you to do in your best interest what is best for that patient. All right, perfect. So solid drugs, as you can see here in the picture, pills. So capsules, tablets, pills, and suppositories. Most medications are given by mouth or to adult patients, or in a tablet or capsule form. Capsules are a gelatin shell filled with a powder or liquid substance inside of it. Right? Tablets are often contain a material or other materials mixed with the medication and compressed under a high pressure. Some dissolve very quickly in small amounts of liquid. Some take a little bit longer. They can be taken sublingually, like nitro, or absorbed rapidly, like what medication? What medication for nausea can be given that absorbs rapidly on the tongue, which is an AEMT medication? Zofran, perfect. All right. They can be taken sublingually or absorbed rapidly. They may be ground up into a powder and absorbed more quickly as well. As far as pills go, they're a solid drug that is shaped into a ball or oval to be swallowed, and suppositories are inserted into the rectum, which is not administered by the AEMT. Now, that's the national scope of practice. All right. So, what medication can we assist rectally with? Assist. I didn't say administer on your own, but assist, which is more of a state allowance versus national protocol.
Tylenol.
Valium. diazepam. So for kids with seizures, we have the ability to assist with Valium as well. Tylenol used to be there, so they took that away. It used to be in the drug boxes in New Hampshire 10 years ago. But they took away rectal Tylenol away from that. It was for fever treatment. But they don't want us treating fevers anymore. So, all right, liquid drugs. Solutions are a liquid mixture of one or more substances that cannot be separated by filtering or allowing a mixture to stand. Can be given by any route. A suspension medication is a medication ground into fine particles and evenly distributed throughout a liquid by shaking or stirring. An example would be activated charcoal. Another medication like that as well that's separated but then pushed together is Solumetrol, Solucortef. Other suspension other liquid drugs that include alcohol in their preparation, like spirits, elixirs, things like that, or syrups, which are mixtures of a higher sugar content, or emulsions, which are mixtures of two liquids that are not mutually soluble. This is what they call a metered dose inhaler. Everybody should be very familiar with this, as it's an EMT scope of practice medication to assist with, which is a miniature spray canister used to direct substances through the mouth and into the lungs through an inhalation. Delivers the same amount of medication. That's why they call it metered dose. So that way it delivers the same amount of medication each time it is used. You have to shake it vigorously before the medication is administered, because the inhaled medication is usually a suspension inside, which is commonly used with patients with respiratory illness such as asthma or emphysema. Topical medications are applied to the surface of the skin, which affect only the area of application. However, there are other topical medications that are done through a patch form that can also be dangerous. Lotions, which absorb quickest through the topical medications, examples would be like calamine lotion, or different types of ointments like creams and ointments, or hydrocortisone cream, or Neosporin first aid ointment, which are a slower rate of absorption from ointments. One other, let's say topical, but a patch medication that's out there is very common, are lidocaine patches for pain management. And I've seen fentanyl patches. Now, I've seen patients overdose on fentanyl patches too. I've seen that happen a lot in nursing homes as well. And they start chewing them up, and then you go there and like, how can she overdose? Well, she ate 15 of her fentanyl patches. No wonder why she's worked out of her mind, right? So they end up getting enough Narcan and waking them up. Transcutaneous medications like transdermal, which is more like the fentanyl patches, or nitroglycerin. So as you're doing your assessment, you need to make sure you're wearing gloves. What would happen if you got nitro ointment, like a paste, or if you got any kind of nitro patches on your skin? What would happen to you? Right? Headache, or it potentially could pass out, right? So designed to be absorbed through the skin, it can affect other areas of the body. Examples would be the nitroglycerin or fentanyl patches, usually indicated for a systemic effect. Gels are a semi-liquid substance which are administered orally through capsules and plastic tubes. As you look here, we have glucose tablets, or like a glucose 15, like oral glucose we administer at the EMT level. Consistency of pastes or creams, but are transparent, like oral glucose. We have different gases that can be administered, oxygen being one of the gases that are there. So nitrous oxide may also be administered to reduce pain for orthopedic pain. And this is administered either through inhalation or through a mask. Some routes of drug administration. Route administration affects the rate at which the onset of action occurs and may affect therapeutic response. Like my goodness, I can't speak today. Internal drugs, which should be administered along any portion of the gastrointestinal tract. Oral, take as long as 1 hour to absorb to occur. Or rectal, which again no AEMT medication administered rectally. The possible exception of D50 if allowed in local protocols. I've never seen D50 given rectal before, but Valium may be an option in the pre-hospital field. So parenteral drugs administered through any route other than the gastrointestinal tract, like intravenous, which is the fastest delivery but cannot be used for all medications. Medications need to enter the bloodstream immediately. Or interosseous, which reaches the bloodstream through the bone marrow for patients who are unresponsive as a result of cardiac arrest or extreme shock. Most cases are most commonly used for children who have difficult access for IV sites. Same thing for adults. 2 attempts, 90 seconds. You can't get an IV, go for an IO. Intramuscular, subcutaneous injection, absorb more slowly and have a longer lasting effect, and less effective for patients with decreased peripheral perfusion. Intramuscular IM injection, usually absorbed quickly because the muscles are highly vascular. Once you administer an IM injection, though, whether it be in the lateral thigh, the buttocks, deltoids, you want to make sure you massage that muscle to disperse that medication thoroughly through the muscles. It also reduce the pain after the injection for some patients. Some possible problems would be damage to the muscle tissue and uneven, unreliable absorption. That's why I said massage the site. Another thing too is sublingual medications as well, is they enter the bloodstream through the oral mucosa or mucous membranes within minutes. So one of the medications we administer for that would be nitroglycerin, which is faster than oral route and protects medications from chemicals in the digestive system, like nitroglycerin tablets. We have buccal administration. All right. So what would be a buccal administration? Remember that one at all? It's similar to a sublingual oral glucose. So how many providers out there have just said, here you go, here's some oral glucose, and they just put it in their mouth and they just squeeze it? Who's done that before? I think we all probably have or seen it done, right? Right. Technically, we're supposed to put it in the corner of the mouth between the cheeks and the gums. Doesn't always happen that way. All right. And with the new packs they have out there, they don't have these specific tubes. Yeah, exactly. Swallow this, right? Instead of actually giving it buccal. So common route for oral glucose gel. We have transcutaneous or transdermal, which is absorbed through the layers of the skin. What used to be an advanced level or intermediate level back in Maine was years and years and years ago was the nitro transdermal. The nitro paste, they took that away years and years ago. Intranasal medication, which common one that we give would be naloxone, is a medication pushed through what they call a MAD or a mucosal atomizer device. It's a liquid turned into a spray with quick absorption. Then inhalation, where drugs are aerosolized and drawn into the lungs as the patient breathes. One that we would be administered, it would be albuterol or a duoneb, which is albuterol and ipratropium bromide. Other forms of aerosols, fine powders, and sprays. So the pharmacokinetics are a movement of a drug through the body. So the drugs modify existing functions of tissues and organs. They do not give new functions to tissues or organs. They generally cause multiple actions rather than a single effect. So once administered, drugs go through 4 stages. They call it absorption, distribution, metabolism, and excretion. So how it comes in and how it exits the body and what happens inside. All right. One second. All right, I'm back. So the principles behind this would be the medication dose, route of administration, and clinical status of a patient will largely determine duration and effectiveness of the medication. The onset and peak of medication generally related to absorption and distribution. A minimum dose or concentration of medication must be present at certain sites in the body for clinical effects to occur. The duration of action is generally related to metabolism and elimination. And then drug absorption variables affect absorption with the nature of the absorbing surface, blood flow to the site of administration, solubility of the drug, the pH of the drug or of your body as well, the drug concentration, drug form, route of administration, bioavailability, diffusion, osmosis, filtration. All these things play a part on the medication. Then we need to talk about drug distribution, which the drug passes freely and quickly out of the vascular space and into the interstitial fluid, where blood flow then blood flows to the area determining the amount of drug reaching a particular part of the body. Some areas of the body, such as the brain and placenta, are less accessible to certain drugs than others. Biotransformation is a chemical alteration of that substance that undergoes in the body, primarily the organ in the liver. So you'll talk about biotransformation and the what they call the first pass effect, right, where the drug first passes through that liver to start that process of going through the system and also working towards the next part, which is drug elimination, excretion. So the elimination of a waste product from the body is excretion that can be done through defecation, urination, things like that. Drugs are eliminated through the original forms or as they metabolize. They can be done through intestines, kidneys, lungs, sweat glands, mammary glands, and the rate of elimination varies with the amount of drug in the body that an underlying condition of the excretion organs. So a patient's poor ability to eliminate a drug may lead to accumulation of the drug in subsequent doses are given, resulting in toxic effects. So consider for patients in shock and for the geriatrics. So there are medications that we administer that can have effects, which is why we kind of like half dose certain medications. So my recommendation would be is before you start giving these meds is to contact medical control and ask them, what do you think? Have that consultation. All right, almost there. Pharmacodynamics. Or the way in which a medication produces the response we intended, also known as the mechanism of action. So having the understanding of the mechanism of action will help you determine what is going to happen within the system. It also includes factors that may alter the intended response and any side effect or unexpected effects you may come in contact with. So the mechanism of action, drug must reach the appropriate concentration as its site of action you're trying to get with. The magnitude of response depends on the dose and time it takes for the drug to travel in the body. So IV medications like, for example, Solumedrol takes about 40 to 45 minutes to actually get into the body system. So Medications may also bind to a receptor site. They could change the physical properties of the cell, chemically combine with other chemicals that are there, or alter a normal metabolic pathway. So after medication is bound to the receptor site, it initiates a chemical change that produces an expected effect. Give me an example of a medication. Go ahead and pick anyone that you could administer and give me the mechanism of action of what that you think that would be. Someone try to give me one, see what you have. Almost done, let's get through it. We're getting there. Any thoughts? So if I said, I'll just pick one for you. Who wants to jump in on this? Let's say nitroglycerin. We're almost there, guys. We're almost there. Less than 10 slides left. All right, fair enough. Tell me the mechanism of action of nitroglycerin. You guys should all know this because it's an EMT drug. What's going on in this? What do you expect to happen if nitroglycerin was given?
Blood pressure will increase.
Okay. Well, nitroglycerin blood pressure would decrease, right? Increase.
I'm sorry. Yeah, sorry.
Yeah, I know what you meant.
Blood pressure will be. Okay.
What else? All right, so in hope that, okay, so Mike said to allow or reduce pre and after load, right? So we're making a container bigger, right? We're vasodilating, correct? Right? Like Jen said, pain is decreasing. Hopefully that will open up the vessels, allow for more oxygen transport, right? What else? All right, we'll move on. I know you guys are getting tired. It's getting late. Almost there. So the drug response relationship correlates with the amount of medication given and response it causes. So when administering a medication, you need to know the onset of action, how long the duration of action is, and when the termination of action happens. Epinephrine, onset, rapid. Duration, 5 minutes. Termination of action, it stops. We need to do the next dose, right? The onset, duration, termination of action affects the therapeutic index. So the ratio of a drug's lethal dose is 50% of the population, what they call the LD50, to its effectiveness for 50% of the population, which is called the ED50, right? This gives an indication of a medication's margin of safety. And the therapeutic threshold is the minimum concentration required to produce the desired response. So if a patient has pain, I know this is more of ALS, if a patient has pain, do I give 500 micrograms of fentanyl? No, that would kill a patient, right? So I want to make sure I look at giving the therapeutic threat, the minimum concentration required. That's why things become weight-based. Weight-based medication administration is helping with that therapeutic threshold so we don't give too much and we're looking at that desired effect. Then we can titrate it after that and say, okay, I gave 100 of fentanyl. The pain is still there. I wait 10 minutes, give it the next dose, right? Right. So that's how we work things. If we had a patient who's a diabetic, do we give them 3 bags of D10? Absolutely not. We give them a half a bag of D10, check up blood sugar and see how things work. We go to the next half, right? Just because the entire medication's in that vial or bag doesn't mean we have to give the entire thing. Some we have to, but not every single time. We make sure we give enough to meet that therapeutic effect that we're looking for our desired response. Factors influencing medication interactions may many variable influences medical interactions with this. So the interaction between medications occur when actions of a drug on the body are modified by another chemical substance, like another prescription med. That's why it's so important that we look at the medications the patient currently has prior to us giving another medication that's in our drug boxes. Herbal or over-the-counter meds, nicotine from cigarette smoking, something that they're using for their diet, anything to which the patient is exposed to. So be aware of potential interactions of medications that are prescribed and those the patient may be self-administering, like polypharmacy. You may have polypharm overdoses. It happens. We've seen patients, and I've had them recently. Interaction with food or alcohol. Some medications have reactions. That's why there's warning labels on prescription bottles. Predictable responses, like side effects, any action of a medication other than the desired action. So if I said nitroglycerin, what's a side effect of nitroglycerin? You guys already gave me two of them, right? Hypotension, headaches. Okay. So understand what the side effects are. How about iatrogenic responses, tachycardia, adverse conditions inadvertently induced by a patient treatment given. Example, a urinary tract infection develops after insertion of an indwelling catheter. We put in a Foley catheter, and for some reason, it wasn't very sterile. Result of the administration of medication leads to symptoms that mimic natural occurring disease states. An unpredictable response is an adverse reaction that is not anticipated. All right? If you give somebody Benadryl and you push it too fast, okay? You do an IV fast push, the patient can develop significant chest pain like they're having a heart attack. That's why you push it slow. That's a common reaction to Benadryl administration if given too fast. Serum sickness, like delayed reactions. Hypersensitivity, similar to an allergy. Idiosyncrasy, which is a complete, unique response specific to that person and not seen in other patients. Tolerance, decreased response to the same amount of medication. So patients that are opiate users, if you give them 50 of fentanyl for pain, do you think it's going to touch them? People should be saying no. They've built up that tolerance, right? Often seen in patients who take pain meds. This is, like I mentioned before, this is something that happens a lot. They're on oxys all the time, you know. Cumulative effect, increase the effect of a medication is given in several successful doses, which might result in a therapeutic or non-therapeutic effect. Drug dependence is another one, all right? So we look through all these different ones that are here. Like drug interaction affects one or more medications, alter a response of another medication. So we give this med and this med, right? Then it alters another medication that we may administer. And that's what I was talking about earlier with nursing homes. We see a lot of that where they're on 20 different medications because one counteracts the next, which counteracts the next, right? Awesome. Good description of a mechanism of action for nitro, Mike. Thank you. All right. So we talked about this right here. Reduction in medication errors. Okay, medication errors happen more often than you think. So decision is often based on the memory and frequency or frequently occur in the context of stressful, life-threatening patient situations. We want to make sure we use the right patient, right medication and indication, dose, route, time, patient education, right to refuse, right response and evaluation, right documentation. Right? Those are all the different rights of medication. Or reducing medication errors, as you can see here, with angioedema. So use reliable medication references source whenever administering potential unfamiliar medications, whenever an unusual dose or route of administration is being considered. Have your partner confirm the volume in a syringe or a weight-based medication calculation. confirm with your partner. I check every medication 3 different times before I give it to a patient, every single time, to make sure it's the right med, right dose, and why am I giving it, right? All the rights of right patient administration. In this picture you see here, this patient has significant angioedema, okay? Kind of a helpful side tip, if you go into a patient that has angioedema at home and they didn't get themselves in any medications, not sure why the tongue is swelling, ask them if they take lisinopril. Lisinopril can have a reaction 5 years later. All right, and they're still taking it, all of a sudden they can have significant angioedema. 2 more slides to go and we're done, guys. Evaluate the medication allergy and hypersensitivity before each medication administration. Ask them, do you have any medication allergies? Institute a safe medication practice has developed a list of medication abbreviations prone to causing errors. And to finish this off, specific medications here. An AEMT is allowed to administer or help patients self-administer numerous medications. Administer medications only if a licensed physician gives you a direct order or local protocol. And here is a list of specific medications for you. Oxygen oral glucose, glucagon, IV dextrose, D50, D25, or D10. Intravenous fluids like D5 in water, normal saline, lactated ring, or solution. Epinephrine IM or subcutaneous. MDI medications like albuterol, nebulized medications, albuterol, nitroglycerin spray, tablet, paste, nitrous oxide, naloxone, aspirin, and others based on local protocols. Those medications are the national standard, and then there are some that are there that you can't do in New Hampshire, and there are others that are not listed that you can do in New Hampshire. And that's what the New Hampshire Scope of Practice module is for. All right, any questions on what we just covered?